Assalamu alaikum everyone, my name is Salma Abdelrazik and alongside my friend and colleague Ebraheem Hoda, we'll be explaining your MSK OSPE. Now I'm gonna start off by saying that I'm not gonna lie to you, it is very dense, but if you studied the lectures, which you should have because I have an exam coming up, this should be a breeze and should be really easy because it's basically a recap of everything. I'm gonna start taking the upper limb, like clavicle, scapula, humerus, elbow, and hand, muscles, bones, and everything from that sort. And Ibrahim is gonna take the lower limb, and we divided the histo accordingly. But until we come up to the histo part, I'll tell you what exactly we're taking. But we're gonna move in orders of your lab. Okay? Okay. Let's start with the upper limb. We're gonna start off with the clavicle. Okay, okay. Before we start anything, you need to know the basic movement or terms of movement. Like for example, that this is abduction or abduction, this is adduction, flexion, extension. And I bet that you guys already know this from your first block ever. So we're just gonna move through it, but this is there for your if you want to recap at some point. Let's start off with the clavicle. Clavicle looks exactly like this. It's just a small bone that has two sides. We have a sternal end, which rhymes from the term sternum, because it attaches to the sternum from that side and it's rounded. Let me explain it off. And then you have the acromion end, which is basically the lateral part, because laterally you have something called acromion, and that's where the clavicle attaches to the acromion from the acromial end. Okay, okay. And then there's the posterior aspect, and there's the anterior aspect. Okay, now suddenly you have a shaft and you have these articulations or place for attachment here and there. And that will be explained in the next slide. Don't take a sneak peek. But just know for now that, again, the sternal end is here. We have a facet of articulation with the sternum. Look, okay, I'm going to try my best to draw the sternum. It's just something like this, attachment, all that. So we have like an empty, shallow circle here in which we have the clavicle attaching. So it's like, okay, yeah. So it's basically the sternum is attaching to the clavicle. Awesome, awesome. And yeah, so this is the sternal end. And then you have the acromion. When you have this line, it's called the trapezoid line. Cool? Cool. And then you have the group for subclavius muscles. So the muscles under the clavicle is going to be called subclavius because sub is under, clavicus is clavicle. And yeah. And then you have the conoid tubercle and trapezoid line are for attachment of the two parts of the coracoclavicular ligament on the inferior surface of the clavicle. Put a star beside this because we're going to get back to it later on. But for now, just know laterally you have the acromion, medially you have the sternum. So according to that, the name of the clavicle end. And then you have here the attachment for costoclavicular ligament. Let me summarize it here so when we get to it, you already know a back history. Costo is like ribs, okay? Clavicular is clavicle. And that will be explained later. And then here we said coracoclavicular, we have something is called coracoid. It's also related to the scapula and the clavicle. And then clavicular is clavicle. Cool, cool. Type. Now that I showed you these two images, this one and this one, you're telling me you know which one is superior and which one is inferior? Let me tell you how to tell the difference between superior and inferior. Superior surface is smooth. Inferior surface is rough. Why is it rough? Because it has anchors, and by anchors I mean like articulation sides, I guess. Like articulation sides, my bad, with a T, my bad. Sides. Like over here, this part that we send. But if you're looking superior, it's gonna be so smooth. Okay? Okay. Why? Smooth because it's right under the skin. It's subcutaneous, so it has to be smooth so it doesn't like bother you. And it has nothing to attach to, so there's no ligaments or muscles attached to it, so that's why it's smooth. But the inferior side is rough because it has the anchors that stabilize it downward. Basically, it has ligaments attached to it. And those are the pictures. So it's smooth, you could tell. And it's labeled, but I would have asked which one is acromion, which one is sternal. And like we said, the acromion is like lateral and sternal is medial. Okay? And we knew this because the posterior side is here, like pointing that way, and the anterior side is pointing that way. We have the medial 2/3 and we have the lateral 1/3. And we'll talk about these later on. So that's why we know which side is anterior, which one is posterior, medial, lateral, all this. I'll explain it later on. And here's the inferior side. It's basically more rough. Cool? Cool. طيب, how do I know if it's left or right? And according to that, we'll know which side is the acromion and the sternal and all that. Like we said, we have median 2/3 and lateral 1/3. Cool? Cool. We have something called concave side. We have convex side. Concave like a cave, so it curves inwards. Convex like a lens, it curves outwards. Basically, the medial part is the concave over here. Like if you're putting it straight forward like this, when you see a dip, like a concave, it's going to be medially. And when you see an outer side is convex or pointing, projecting outward, it's going to be the lateral part. And how would you know? Because you already know superior and inferior. So you hold superior and inferior, see which side has the dip, which one has the rise, and according you adjust it. Okay, so we said the lateral part is convex, this one is concave. Make sure that your interclavicle so smooth edge is superior, exactly. So acromion tells you which direction the clavicle is. If acromion is to the right, which is the most lateral part, then you have the right clavicle. If it's to the left or end pointing to the left, so it's the left clavicle, and so on. Okay? Okay. Awesome. Awesome. Now we told you everything about the bone itself. We have to know the attachments of the bone. So the ligaments. And like we said, attaches to the rough surface or the inferior surface. Okay, we have three ligaments that are very important to know. You have costoclavicular ligament, like we said between. It's between the rib and the clavicle. So it attaches to the medial end of the clavicle and it's very strong. So if you would zoom into this picture, it's over here. Costoclavicular over here. It attaches to this, the rib over here and the clavicle. Sure, sure. Then you have coracoclavicular ligament. So it's between the coracoid process and the clavicle. It's made up of two ligaments. You have the conoid ligament and you have the trapezoid ligament. Conoid is more median, trapezoid is more lateral. And this is one of the strongest ligaments. Okay? Okay. Let me show you on the picture. You have coracoclavicular ligament. Here's the coracoid process, and here's the clavicle. And it's divided into two. You have the first one over here, conoid ligament, and you have the trapezoid ligament. Here's the, let's put the line. Trapezoid. Awesome, awesome. Both of them together make up the coracoid or coracoclavicular ligament. And then you have the last important ligament. There's more, but we're just talking about the very important ones. We have acromioclavicular ligament. So it's between the acromion and the clavicle. It's the most lateral end of the clavicle, hence the acromion. And it's the weakest of all three ligaments. So the strongest is the coracoclavicular, the weakest is the acromioclavicular. And made there, this is foreshadowing the things coming. Here it is. Acromioclavicular connects the acromion ligament with the clavicle. Awesome. Ignore everything else because they're basically spoilers to what's coming. So let's say this is the same thing we just said in the last slide. You have the coracoclavicular ligament over here. Like we said, it's the strongest one because it has two attachments, 1, 2. It's divided into conoid ligaments and trapezoid ligament. And this coracoclavicular ligament, like we said, yeah, it's divided into trapezoid and conoid. That's what. And it's the strongest. That's why I put 3 stars. Now let's say we have the acromioclavicular ligament. It's the weakest, so it gets 1 star. And it connects the clavicle with the acromion. And like we said, okay, imagine with me. Taban, these are two different things joined together, the clavicle and acromion, like this, by this ligament. But just imagine it like more of a circle thing. So here's the clavicle and here's the acromion. So this rotated thing is acromion. Cool, cool. And it seems rotated, but it's actually just like a thickened edge of, you'll understand later on. And then we have this thing projected from it, and this is called the coracoid. This is just a joint. Taban, for every ligament, there's a joint articulated between each bone and the other. I don't know if they're expecting you to know it, but let's just highlight some of them. Sternoclavicular joint is very important. And you have the, here it is, acromioclavicular joint. Let me just circle it and put 2. Okay? Okay. Everything else we're going to cover in the right time. Next. Another picture. But this one, I just thought it summarizes everything this yapping picture says. We have the AC ligament, CA ligament, CC ligament. Let's talk clinical. What would happen if the clavicle fractured? Most often, the fractures happen in the point in the clavicle that connects the medial 2/3 and the lateral 1/3. So it's basically where the convex meets the concave, this part, which is medial 2/3 with the lateral 1/3. Cool? Cool. When the clavicle does fracture, the medial end goes up. Why? Because it's pulled up by the sternocleidomastoid muscle. Cool? Cool. What about the rest of it, the lateral one? Okay, طبعا I put here sternocleidomastoid. It basically attaches to the sternum, clavicle, and mastoid from the name. Sternum, cleido, clavicle, and the mastoid. The lateral end goes down. Mostly cause of gravity. It just goes down because of gravity. But there's also other muscles acting on it that pulled it like inward or down. It's the pectoralis and the subscapularis. You should know this. I tried putting it in a good picture. So gravity drops the lateral fragment, pectoralis major pulls arm inward, causes overriding, and that's why the medial goes on top of the lateral. So instead of them being like this together, it will be like that. And the sternocleidomastoid elevates the medial fragment. And this is the picture that he got you. Cool, cool. We're done with clavicle. Scapula. You have to know that it's a ball and socket joint. That means it's freely moving. It can move up, down, left, right, away from your body, towards your body. It's free range of motion. Okay? Okay. Let's zoom into the simple one first. Scapula is like a pizza slice. And pizza is triangular, so that means it has 3 angles, 3 borders. Cool? This one is pointing up, so it will be the superior angle. Beside it would be the superior border. And this one is lateral, or pointing away, so it's lateral angle. With it would be the lateral border. And this one is down, so it will be the inferior angle. This one is pointing to the medial. The border is pointing to the medial, so it will be the medial border. This is basically the scapula medius. طبعا we have a spine of a scapula or whatever that divides it into up and bottom. We'll explain that later on. But for now, just let's look at the other picture. You have the spine of the scapula. Acromion angle is basically a connection of the spine itself. Sure? Sure. Acromion angle, like we said, acromion is lateral, so it would be the lateral angle. You have the medial border, inferior angle, lateral border. Cool? Cool. More pictures, because what else do we got other than pictures in OSPE? All right. This picture looks like so much is going on, but it's just literally giving you minimal information. So we have this beautiful, beautiful person that did this. I don't really know the name, but if you're the one that did it, good job. They labeled it. Too bad that the quality sucks. But I feel like I can see, personally, I can see like in real life. So I don't know about you if you can see it, but quality's terrible. So just refer to this one, but it's the same thing. What we're trying to say is scapula has processes, borders, and angles. Green are angles, so we have the inferior angle, here's the inferior angle. Different views, like one of them is like the coastal one of them is the posterior, one of them is lateral. Okay. Like we said, this is the body of the scapula. We have 3 angles, superior, lateral, and inferior angle. With the lateral, we have the lateral border. With the inferior, you have the medial border. And with the superior, you have the superior border. Awesome. Awesome. And processes, you have one process here, and it's acromion. You have another process when you look laterally, which is the coracoid process. Cool? Cool. And yeah. And then you have the spine process when you turn posterior. I hope that makes sense so far. Quality is sandy. I'm sorry, guys. We have supraglenoid tubercle. We have infraglenoid tubercle. Before saying what's so special about them, let's point them out. This is the glenoid cavity. It's basically where the bone of the arm, which we're going to call it humerus for now, attaches to that fossa. That's where the arm and the shoulder literally come hand in hand. Cool? Cool. Above it will be called supraglenoid. And since it's like a notch or like a tubercle, we'll call it tubercle, supraglenoid. And since we have supraglenoid, we have infraglenoid tubercle. Cool? Cool. This is all on the lateral view. We said the supraglenoid, what's so special about it is that it attaches the long head of biceps. Infraglenoid, long head of triceps. Think about it. Biceps come up, triceps come down. So supraglenoid tubercle has the long head of biceps, infraglenoid has the long head of triceps. And then you have something called the suprascapular notch. Supra means up. Scapular, scapula. And notch means it's like an indentation. Let's look at this. It's clear on the posterior and the anterior view, or the costal view. Suprascapular notch, it's basically like a hole. 2 things go through this hole. The red is going to be the artery. The black is going to be the nerve. Type. Are these the only 2 things that go through it? Yes. This is if he asks you about the notch, he basically wants to say the nerve and the artery. And they're both called suprascapular nerve and artery. So from the notch itself, or from the place itself, you can get the name. How do you tell the difference between the costal surface and the posterior surface? Like, how do you know if you're looking at the scapula, you're looking at the back or the front? Costal surface is going to be smooth. Okay? Costal is basically, if you're looking at me like this anterior, costal surface is the one looking this way. Posterior surface or the dorsal surface is the one giving to the back. Easy? Easy. Dorsal surface is divided by the spine into area above the spine, it's called supraspinatus. Area below the spine is called infraspinatus. Cool? Cool. Picture, this is the spine, end of the spine is acromion, above it is supraspinatus fossa, below it is the infraspinatus fossa, and we have the glenoid fossa in which the humerus attaches, like that, and coracoid process. Easy, easy. Here we go. Like we said, there's suprascapular nerve and artery. Why did we say that the artery go on top of the nerve? Because the artery pumps blood, so it needs to expand. If it was to be under the nerve, nerves don't expand, they don't pump blood. It would have been compressed at some point if it needed to expand. There's no space for it to expand. That's why it comes to the top. So imagine this is the notch, there's the nerve going on here, and this is the artery going on here. If the artery can want to expand, so it can expand since it's open, but the nerve can't. That's why the nerve doesn't expand, it's down. Cool. Cool. We already said this, we have the lateral view or lateral angle, we have supraglenoid tubercle, infraglenoid tubercle. And the lateral angle is modified to give the glenoid fossa, which is over here. Superior to the glenoid, supraglenoid tubercle. Inferior would be the infraglenoid tubercle. They're there for muscle attachment, and I'll spoil it for you. I already did up, but just know that again, like we said, supraglenoid is the long head of biceps. Infraglenoid is the long head of triceps. Cool, cool. More pictures. Like, oh my god, we have supraspinatus above the spine, infraspinatus below the spine, lateral border, inferior angle, medial border, infraglenoid tubercle, supraglenoid you can see from here. You have the acromion process, glenoid fossa. Next picture, supraspinatus, infraspinatus, medial border, lateral border, inferior angle, humerus, spine. So supraspinatus, like we said, infraspinatus, acromion process, glenoid fossa. Cool? Cool. And we're done with the scapula. Now let's continue the shoulder, and what attaches to the glenoid cavity is the humerus. This is what the humerus looks like. Let's zoom in and take it one piece at a time. You have the head. Clearly, it looks like a head. Like, it looks like a human head. I'm just kidding. This is me in my head. So this looks head. Then you have something called greater tubercle, and you have a lesser tubercle. And they're both very important. We're going to be talking about them later. Then this is the surgical neck of the humerus. And somewhere over here, this red line is the anatomical neck. And you have the deltoid tuberosity. Deltoid is a muscle. We'll talk about it later on. And tuberosity is basically an attachment landmark for that muscle. Cool? Cool. That's going to go down. And you go down, about all this is called the shaft. Then you go down, and you have this bulging thing that looks like two things. One of them is this type, and one of them is this. They're called trochlea and called capitula. And then you have the medial epicondyle, which, like we said, points towards the body medially. And the capitulum is more lateral. Okay? Okay. You have medial epicondyle. This is lateral epicondyle. Cool? Cool. Let's take a look at the other side. This is posterior view. We have the lateral epicondyle. We have the medial epicondyle. So from the back. Now imagine with me, you have something like this. So something attaches to it, and then it just goes to the front like that, right? So it's basically, this is the posterior view. So you only have like one fossa or something. From the front, it looks something like this. And no, you have the capitulum thing. Capitulum is over here, trochlea, and the medial epicondyle is like that. And then the rest of, if it attaches to the radius ulna, to look like that. So it's basically, this can bend forward and backward. And here it can bend forward and straighten this to be straight. But yeah, this is how to know from anterior or posterior. You have this empty fossa over here, which will be called olecranon fossa. That's what this whole drawing I was trying to do is about. Cool? Cool. This is a simple thing I just made way too complicated. We have the head, you have greater tubercle, lesser tubercle, surgical neck, deltoid tuberosity, capitulum, trochlea, medial epicondyle, lateral. That's all you have to know. To tell the humerus is left or right, look to the head. The head points medially. So since this is going to this direction, imagine it's your hand. Now, this looks like this in real life, guys. So, like that. So it goes this way, so that means it's the right. And this one, this head goes this way, so that means it's the left. Cool? Cool. Same with medial epicondyle. Medial epicondyle points medially. Same with the head. Cool? Cool. So humerus is a long bone, neck tubercle. It's look at the head and the medial epicondyle. That's it. More pictures, yay! We have the head of humerus, greater tubercle, which is very important. Like we said, we have lesser tubercle, also very important. We have the intertubercle groove. That means between two tubercles, so it's called intertubercle, so it's between. Then there's the surgical neck, and it's anatomical neck, yeah? And the lesser tubercle. Next. We said intertubercle groove, and we said there's something special about it. It is the... Okay, let's not read this line. This is basically a summary. We said it's found between the greater and the lesser tubercle, intertubercle. It's attachment of the long head of biceps brachii. Biceps fin. And we have the deltoid tuberosity, which is attachment site for the deltoid muscle. Then you have the spiral groove for the radial nerve. Spiral groove we'll talk about later, but for now, just know that the intertubercle groove has the long head of biceps brachii. I want to remind you of something. Remember when we said supraglenoid? So it's connects supraglenoid and it passes through the intertubercle groove. Awesome. Then you have the trochlea. It has an attachment to the ulnar bone because, like we said, it's medial. Capitulum is lateral, so it has attachment to the radius. Let's take a look. Supracondylar, because I think this part is called condylar, so supra means above him. This part, oh, I'm not pinpoint. Anyways, then you have the lateral supracondylar ridge. We said there's the coronoid fossa. And then you have the radial fossa. Okay? Okay. So above the trochlea, let's imagine it like this. You have the coronoid fossa. Above the capitulum, you have the radial fossa. This is the lateral epicondyle as usual, medial epicondyle, and lateral supracondyle ridge. And then from the back, we have the olecranon fossa, medial epicondyle, trochlea, and so on. Trochlea, you can see it because of this thing. I keep drawing, I don't know its name. But yeah. We have the radial fossa above the capitulum. We have the trochlea, above it is the coronoid fossa. Medial epicondyle, lateral epicondyle, lateral supracondylar ridge. Trochlea is with ulna, capitulum is with the radius bone. We have nerves and fractures. We got the bone, we finished the landmarks, we said this is here, this is there, blah, blah, blah. Let's talk about the nerves that actually go through. We have axillary nerve. Let's name the place it is at. Axillary nerve at the surgical neck. Radial nerve is at the shaft. Humeral shaft. Right? Now, median nerve, let's keep this for later on. Let's not talk about this. Median nerve, it's here at the end. So this part is called the supracondylar. Oh, just supracondylar pair. Okay? Okay. So, if there's a fracture at the surgical neck, that means the axillary nerve is going to get affected. If there's a fracture at the humeral shaft, the radial nerve is going to get affected. Supracondylar fracture, the median nerve is going to get affected. And along with each nerve, we have an accompanying artery. So axillary comes with a posterior circumflex humeral artery. And this is memorization, guys. I don't even have mnemonics for this. Like, I memorized it. But it's axillary nerve with the posterior circumflex humeral artery. And then the humeral shaft has the radial nerve and the deep brachial artery. Supracondylar fracture has the median nerve and the brachial artery, not deep. And here's the picture that he might bring, by the way, guys. These are the pictures. Like, away from all the yap, he's literally would get you pictures. That's it. So a fracture of surgical neck occurs most commonly in adults from a fall on outstretched arm. Fractures of the mid shaft, supracondylar fracture. Supracondylar, we said, will affect the median nerve. Mid shaft is or radial nerve. And the surgical neck is the axillary nerve. Cool? Cool. And then we have something very important, which is sits. Sits is basically the rotator cuff muscles. And like it's rotator cuff, you imagine your hands like in, you know, when like it's cuffed up, so it's like this, it's fisted, and then rotator because it seems like you're about to rotate your hand. There's probably a better reason why, but this is how I imagine that in my head. These pictures basically say everything we said up, lower, this is head, this is greater tubercle, lesser tubercle, anatomical neck, surgical neck, and so on. I want to focus on here, and this picture down here. It seems like it has spaces like 1, 2, 3, and this is just from the side that we can see the greater tubercle. Greater tubercle is very important because it's like a side that has 3 attachments or facets, as you can see. We have superior, middle, and inferior. Superior is attachment for supraspinatus. Middle is attachment for infraspinatus. Yani they always come together. Superior and middle is going to be like top, bottom, so it's superior, middle, supra, and infraspinatus. And then you have the inferior facet for teres minor. I feel like this picture doesn't do justice. So how about we just go to another picture? Makes it easier. First off, the sits are 4, I want to say like muscle attachments. We have supraspinatus, infraspinatus, teres minor, and subscapularis. Greater tubercle can handle 3, that's why it's greater. And the lesser tubercle can barely handle 1, so it's lesser. You should be able to remember something like that. So it sits from top to bottom and will be used by the name. And then the lesser tubercle has just the lowest one. So how? Supraspinatus. Remember the scapula had like a spine thing? And then this is supra, this is infra, teres minor, something else. And then you have the subscapularis. Okay. So you're going in order. So it will be supraspinatus. Supra, so it's like up, like it's so good, supra. And then infraspinatus right under it. And then you go teres minor, minor. And then finally the subscapularis, because it's way under a whole bone, guys. Like that's crazy. So it will be sits, supraspinatus, infraspinatus, teres minor, and subscapularis. And all these 3 in the greater tubercle. This one is in the lesser tubercle. Cool. Cool. Awesome. And this is basically a summary table that I made for you guys. I don't think you should need to know the clinical test, but I'm putting everything for the sake of completion. You just focus on the nerve and the main actions. I'm going to go through this table. Others are just for summaries. Just like a recap of everything I said. Supraspinatus by suprascapular nerve. Subscapularis and infraspinatus, also they have they're all related to the scapula. So there'll be suprascapular and upper and lower subscapular, because this is subscapularis, so it's subscapular nerves. Supraspinatus, infraspinatus, they're still in scapula, so it's suprascapular, suprascapular. The actions. Supraspinatus initiates abduction. So it's if your hands are to your body like that and you just move 15 degrees, that's supraspinatus. Infraspinatus and teres minor are lateral rotations. I remember in my head, for some reason, in my head last year, I was like, yeah, these are the only things that do lateral rotation. Don't follow me, there's probably more, but in my head, it just made sense. Infraspinatus and teres minor do the lateral rotation. Subscapularis do medial rotation. Medial rotation. Teres minor is supplied by axillary nerve. Cool? Cool. Okay, take clinical for humerus. This is how a normal shoulder looks like. The glenoid fossa has the humerus head in it, all attached perfectly. Dislocated shoulder. That means it's not in the right place. So the glenoid fossa is here, and the humerus head is here. It's not in, like here. Like it's not attached to the place. And this can happen literally due to any reason in the world. Falling on outstretched hands, getting hit by something, so many reasons. And since we have dislocated, it could be divided into anterior and posterior. Okay, and now we're going to be talking about the dislocations. We have two types of dislocations of the humerus. We have anterior dislocation and we have posterior dislocation. Let's start with the anterior. Anterior dislocation means that the humerus goes in front of the glenoid fossa. So basically, if you zoom in, of course, they're not going to get you the pictures drawn, but just know that the humerus looks like it's in front of the glenoid fossa. Where's my pen? Okay, over here. So basically, it just goes in front of it. And the glenoid fossa is behind it. Obviously, you'll just be looking at the humerus the whole time. But we have the other type, which is the posterior dislocation, which gives you the light bulb appearance. Sincerely, I've never seen what the light bulb appearance means, but I just can't imagine that the glenoid fossa is in front of the humerus. You could see that the borders themselves look very fitting, like the humerus here, and the glenoid fossa is in front. But if you see the light bulb go crazy, write it in the exam. It's correct. Light bulb appearance. And yeah, so this is anterior dislocation where humerus is in front of the glenoid fossa, and posterior dislocation where the humerus is behind the glenoid fossa. That's all. Pictures like these come. They're basically like a good place for questions, Ram. You have to be able to name things. So like we said, this is the head of the humerus. We have that acromion process because it's coming like a spine. Clavicle because it's literally the clavicle, like it's very clear. Then you have the acromoclavicular joint because it's over here. So this is the acromion and this is the clavicle. It's over here, the heel clavicle. So this is the joint connecting between both of them. And then 5 is the coracoid, which is the process coming out of it. And yeah, glenoid is 6, like this fossa over here. And this is another picture which is like with color, so it's easier to see. You have the clavicle, acromion, coracoid, glenoid, and humerus head. Done. More pictures! Yay! Yay, for real. This is an issue here because there's like a separation between the acromion and clavicular distance. Should be less than 8 millimeters. If it's more, there's a problem. Anyways, we have humeral head, glenoid fossa, coracoid process, acromion. Yeah, cool. And here's another table that I put for the nerves and the common injury side. So axillary is the surgical neck, radial nerve is the shaft of the humerus and the spinal groove. Median is supracondylar or in the carpal tunnel or lunate dislocation, and these are just coming later on. Ulnar nerve is medial epicondyle injury. Medial epicondyle. Oh, I didn't say this up in the. I skipped it because I'm so sweet. So ulnar nerve is medial. So if there's a problem with the medial epicondyle, the ulnar nerve is gonna get affected. Anyways, good thing I added it to the table. Right. And طبعا Guyon canal and hook of hamate fracture. Cool. Motor loss will cause problems. Like axillary supplies the deltoid, so you can't abduct from 15 to 9 or 15 to 19. And yeah, radial nerve is the extension because it supplies the extension. Median is the opposition and flexion of the lateral finger. So basically, it's like these, like yeah. Ulnar nerve is weakened Russian, adductor pollicis, musculocutaneous upper arm injury because it's musculocutaneous supplied for the flexion of the upper arm. Cool, cool. Here's summary, basically pictures I didn't know where to put because we already put like a million. Here's the humor. This is how it looks from posterior. This is anterior. It fits in there. More things. Coracoacromion ligament corrects the coracoid with the acromion. We have the coracohumeral ligament, superior glenohumeral ligament, inferior glenohumeral, or middle, I mean, because it comes from the middle. This is the inferior glenohumeral ligament. Because this is the glenoid, so these are under it. This is above it, which is the pink one. Yeah. Anatomical neck of the humerus. And طبعا there's a capsule. It's very important for protection. We have acromoclavicular ligament, connects acromion with the clavicle. Clavicle. Trapezoid ligament and conoid ligament make the coracoid clavicular ligament, and coracoacromion connects the coracoid with the acromion. And the intertubercle groove has the long head of biceps going through. Here's his summary. You can go through it. It's basically a wrap of everything we just said. He talked to you the typus, ball and socket, articulation. surfaces, which is glenoid with the humerus. Capsule is there. Ligaments, like we said, the three ligaments. Stability is because of the rotator cuff muscles and the ligaments. Movements anywhere in the world. Yeah, it's the most frequently dislocated joint in the body is the shoulder joint. Cool, cool. Let's talk elbow. I know there's so much going on, but I hope the flow is going good because we're taking it top to bottom. Elbow, we have three articulations that you need to know. Radiohumeral, which means connects the humerus with the radius. Ulnohumeral connects the humerus with the ulnar. And radioulnar connects the radius with the ulnar. Let's point it out here. We have here, this is the capitulum, and this is the radius, like we said, right? So this part is the radiohumeral articulation. This is the trochlea, which needs the ulnar, so it's over here. Ulnar is bigger, by the way. So it will be the ulnar humeral articulation. And finally, between the radius and the ulnar, we have like, this is here, and this is like an empty thing that I told him. So it's radio-ulnar articulation. Cool? Cool. This is the radius and ulnar. Let's go through it because you need to be able to name it. I remember this coming, because I don't know if I dreamt of this question before exam, it coming, or did it actually come in the exam? But yeah, we have the head of the radius. It's like a circle. And then we have the neck. And then we have a protrusion. It's a tuberosity. It's radial tuberosity systems on the radius. And then this is the radius shaft or whatever, the whole radius. And then we have interosseous border of the radius and ulnar, basically this side. Ignore this for now. We'll talk about it later. And then you have the styloid process. That's that then. And of course, the ulnar also has the styloid process. Ulnar. And we have an ulnar tuberosity over here. It's like I don't know it in English. It's like a hole, basically. And then ulnar and radius. And this is the membrane that connects between them both. We have ligaments. We have radial ligaments. We have ulnar ligaments. Ulnar. We have collateral ligaments. We have annular ligament. We have capsules, so on. Annular is not for ulnar, it's for radial, by the way. Anyways, let's start with the ulnar collateral ligament. It's divided into three parts. 1, 2, 3. Clearly, this is anterior. This is intermediate. And this is posterior. And then we have one that's going transversely. Hold on. Transversely, it's called the transverse band. So the anterior band, intermediate band, posterior band, these three make up the ulnar collateral ligaments, and we have the transverse band. Let's go to the radial side, or the lateral view. Yeah. Radial collateral ligament, it's going this way, like that. Cool? Cool. And then you have the annular ligament, which goes around the head, which is like a circular head, if you remember how the radius looked like. Cool? Cool. These are the ligaments. This is the picture from the models. We have radial collateral ligament going that way to the radius, annular ligament going around the head. This is another view, and this is the ulnar collateral ligament. We have anterior, we have intermediate, and we have posterior, and this is the transverse band. I hate this picture. I hate it because in the other things we clearly said this almost the same things that are covered here, which is basically the identification of the things. So here's the annular ligament. It's going around the radial head. It has quadrate ligament. This is the head of the radius, and a quadrate ligament over here connects between the annula and the radial notch in the ulna. Olecranon, which is the thing that is at posterior of the arm. Like, okay, this is, remember the olecranon fossa? It's basically, this is like a hook, right? And it touches in the fossa of the olecranon, which is in the humerus. Okay, I remember when I drew this thing and I was like, oh, something attaches here and then it goes forward. Yeah, so this is the olecranon. It's like a hook. It basically attaches this way. And this is the fossa, olecranon fossa. Cool, cool. I have olecranon, trochlear notch. These are trochlear notch over here. And yeah, head of the, and there's articular fovea. Head of radius, radial tuberosity, ulnar tuberosity, anterior border, shaft of the ulna. We have the interosseous borders over here, interosseous membrane connecting between the borders. Styloid process of the radius, head of the ulnar. Head is so down there. Head of ulnar is down. Then you have the distal radial ulnar joint. Over here, same thing, trochlear notch, because this affects the trochlea. Coronoid process, radial notch. Yeah, guys. Same things. I hope. Okay. Let's continue. Elbow joint summary. It's a synovial hinge joint because it clearly just flexes and extends. Capitulum and trochlea of the humerus is the articular surfaces, head of radius and trochlea. And I think we have a capsule. The ligaments are ulnar collateral radial. Collateral stability is provided by the shape, collateral ligaments of muscles, and movement is flexion and extension. You have superior radial ulnar joint, inferior radial ulnar joint. They're both pivot, synovial pivot. Hold on. The synovial pivot. Articular surface inferior to the rounded head of the radius. Fibrosis ring formed by the radial notch of the ulna and the annular ligament. But here, the articular surface is the head of the ulna and the ulnar notch of the radius and interarticular disc. I sincerely don't even know why he uses so many words to say something so simple. Like, we already explained all this, guys. Here, the capsule is continuous with that of the elbow. Here, it's a weak and loose capsule. Here, the ligaments are annular and quadrate. Here, the ligaments are very stable due to intra-articular disc interosus and pronator quadratus. Stability here, pronation and supination, which occurs at the superior and inferior radial ulnar joint. Pronation, supination, as if you're holding a bowl of soup, so it's supination. And your stability is mainly due to the ligaments. Remember the word I told you to cross out with up, which was Colles fracture? It's because this is the clinical of the radius. Basically, Colles fracture is the fracture of the radial styloid or distal radius, basically. It occurs in Fuchs. Okay, and there's a broken, or the distal part of the radius does not fall down. Like imagine your radius broke down, it doesn't fall down. Okay, it stays in the position because we have a brachioradialis muscle, which attaches to the broken part of the radius, so it doesn't fall. It's broken. It's like, but it doesn't go, it goes, cool, cool. The sharp edge of the broken radius may affect the median nerve. So Colles fracture affects what? Median nerve. All this you have to tell you, Colles fracture is the broken radius affects the median nerve. And it gives you a dinner fork deformity. It's the dorsal displacement of the distal fragment of the fracture. But yeah, it's very important to know that Colles fracture is a median nerve, and it's because the distal radius is broken and it's held up by brachioradialis, and the dinner fork deformity. And this came, by the way, in our OSPE, and I remember it coming in. Okay, angiogram. I sincerely did not know where to put it, so I put it here because this picture is very important, guys. You have to know the arteries going through. So the arm is called brachial, so it's brachial artery. Whoa. So it's a brachial artery, right? Right. Brachial artery goes down in front of the ulnar, is going to be called ulnar artery. And then there's a branch coming off, is the radial recurrent artery. Minor. And then if you see there's like another one over here, and this is the ulnar, this is the radial. So radial artery. طبعا it continues, it has a common interosus artery, posterior interosus artery because it goes to the back or the posterior. Awesome, awesome. And then it continues and it's going to the front, so it's anterior interosus artery. Because remember, there's the interosus borders and membrane. So if it goes in front of that, it's anterior. It goes posterior, it's posterior. Cool, cool. And طبعا the ulnar artery continues as an ulnar artery. It goes, and then there's another, which is called the over here. It's the radial artery continuing, like we said. And oh my God. I'm trying to take it a step at a time so it's easier for you guys to like visualize with me, right? And then it goes down, oh my God, to the wrist. We have a superficial palmar branch, like your palm. When it comes to supply, you have two arches in your arm and your hand, superficially, and it has its branches, and then deep, and it has its branches. And we'll come to this later on. It's explained later on. And you have the deep palmar arch and superficial palmar arch. Cool, cool. So if he gets you this picture, know if he points up his brachial artery, ulnar artery, radial, he's probably gonna get you the ones that are bolded. So anterior interosus, radial arteries containing deep palmar, superficial, and so on. The hand. Let's talk hand. Hand is so cute, guys. So cute. We have, let's start from here. The radius and the ulnar taban connect. Then you have these. These are called the carpal bones. Above them, which is over here in your hands, it's called the metacarpal bones. And on top of that, you have the phalanges. They're divided into three. You have proximal phalange, medial phalange, distal phalange. Seems pretty easy, right? Up until it's a picture from your lecture. We said the same thing. So this is the carpals, metacarpals, proximal, medial or middle, and distal. Cool, cool. Same with here. Like each phalanx has a head, a shaft, and a base. Wow. Metacarpal has a head, shaft, and base as well. And then sesamoid bones in your thumb. Then these are the carpals. You need to know them all. Which I thought that this literally does not do any justice for it. So I put you the picture that he might get you. Now, you have 1, 2, 3, 4, 5, 6, 7, 8 bones. You have to know all of them. We have hamate. Cool, cool. And it has a place of hooking, so it's called the hook of hamate. It's a big bone. The biggest bone is called capitate. And then you have beside capitate is trapezoid. And then the one nearest to the thumb is called trapezium. The one down, but it's also big, it's scaphoid. It's the one closest to the radius. And that's important. And then you have lunate, which is a small one that could get dislocated. Keep all these terms I'm telling you in your mind because it's very important. Then you have the pisiform, which is one on top of one. The one on the down is called triquitrium. Yeah. And the one on top is the pisiform. Cool? Cool. Let me give you a mnemonic. So we said Sam likes, let me go, to play the tiny cat hissed. We all know which one Dr. Atif told you, so if you like that one more and it's easier for you to remember, just use it. But the clean one that I want to use is Sam, so it's scaphoid, likes lunate, 2, triquitrium, clay, pisiform, the trapezoid, tiny, trapezium, I mean, tiny, trapezoid, C, or cat, capitate, hist is hamate. And we're going in this order. 1, 2, 3, 4, 5, 6, 7, 8. Cool? Cool. Sam likes to play the tiny cat hist. Easy. Cute, I think. All right. And now we're thinking about muscles of the hand. This should be easy, right? I hope this is easy. Muscles of the hand. You see this picture? It's already labeled for you with colors. You have thenar muscles, hypothenar muscles, and the middle hand muscles. They're divided into interusi muscles and lumbricals. Interusi and lumbricals, let's get to it later. For now, let's talk thenar and hypothenar. Thenar is the thick part, because hypothenar makes it small parts, so it's hypothenar. Thinner, hypothenar. And in between, you have interusi muscles, which are the yellow ones, and pink is the lumbricals. Cool? Cool. Let's go down. Thenar and hypothenar eminence. We have 3 muscles that make up these eminences. Foul. We have the flexors, abductors, and opponents. This is the picture he used for you, and we're going to use a better, easier picture, but yeah, I don't think he'd get you the one with this much yap. But like we said, this is the thenar eminence and hypothenar eminence. And keep in mind what each eminence is closer to. Like thenar is closer to thumb, and hypothenar is more like pinky, right? Clearly, pinky. Cool, cool. These are the pictures we said. We have flexors, abductors, and opponents. They make up the thenar and hypothenar muscles. So you'd find, according to the place it is, you have one flexor, one abductor, one opponent. So if it's thenar, it's related to the thumb, you'll find the flexor of the thumb, the abductor of the thumb, and the opponents of the thumb. Same with here. Pinky would have the flexor, abductor, and opponents. But these are not the right terms that we're supposed to be. Oh my god, okay. These are not the right terms that we're supposed to be using. We're going to be using bigger terms, more medical ones. So let's go to the other stuff. We have thenar muscles, we have... So the thumb is pollicis, right? So we said we have the flexor first. This one, okay? Imagine this is where it starts. So imagine if it pulled this direction, because that's how muscles work. It will basically pull the thumb towards here. So it will be flexing the muscle, flexing the, what is it called? The thumb. I have the abductor pollicis brevis. It's over here. It abducts it. These clear, right? These two are like the beginning and end. So when you pull, it's just gonna scrunch the finger. So it's gonna be like, if it's like this, like your hand's like this, and then they both stable here. So you just pull this. You pull, it goes to the front. So it's abductor. And opponents means you can do this opposition. So it is over here. Same thing, opponents, but it's a small one, so it allows to do this. Cool, cool. So what are the thenar muscles supplied by? The recurrent branch of the median nerve. You see this, guys? Do not write median nerve, you'll lose marks. Thenar muscles are by recurrent branch of median nerve. Awesome? Awesome. That's the thenar. We're done because it's related to the thumb. Let's go to the hypothenar, which is the smaller part, which is related to the pinky. Pinky is called digiti minimi. Digit is like a finger, and minimi is the small one, so it's pinky. So cute. Anyway, flexor, abductor, opponents. Flexor, let's zoom into picture. It's over here. Does the same thing, it flexes the pinky. Cool? Abductor, it adducts the pinky. Same thing. And opponents allows it to do this. Cool? Cool. We're done with the hypothenar. We have something called adductor pollicis, which goes to the thumb. Honestly, in the slides, it wasn't very clear it's under folds, under what, but according to everything else, it's a thenar because it's a thumb. So it goes to the thumb. It's only one. Yeah, clearly. Over here. And it does the adduction. See how there's one that's literally abduction under it? This one does the adduction. So if your finger's like this, it returns it back to that. Cool, cool. Deep branch of the ulnar nerve. It's special because it's supplied by the ulnar nerve. And this muscle is pierced by the radial artery as seen on the wet lab. طبعا these are the pictures he uses, which يعني إن شاء الله خير guys, إن شاء الله خير. So we have a rule. The thinner are thumb muscles mostly median nerve supplied by, or innervated by. Hypothenar is the little finger muscle, ulnar nerve. Adductor pollicis is the thumb muscle, but it's ulnar nerve supplied, not median nerve. It's a special exception. Cool. And like we said, we have thenar, hypothenar, and we have middle hand muscles, which are interusi and the lumbricals. Let's discuss this slowly. You have palmar interusi, which is on the palm side. You have dorsal interusi, which is in the dorsal or the dorsum of the hand. Okay. Let's discuss them one at a time. Palmar interusi. We have 3 of them on the palmar side. Let's zoom in. Let's count. This is the second, by the way. Like this is the first anterosy border, second, third, fourth, and yeah. Cool, cool. So it's on the second, third, and fourth lumbar, like or digits or whatever. Cool, cool. And like we said, PAD, that's the mnemonic that he gave you. Palmar anterosy, adducts, adducts, palmar adducts. And if you check for palmar anterosy, how to make sure that it's intact, you hold a piece of paper. And you hold a piece of paper. And that makes it good. So here it is. It's basically adduction of the finger. It pulls the second, fourth, and fifth fingers to the third finger. But yeah, so just know that palmar anterosy does the adduction. Dorsal. Dorsal, we said it's dab. So it does the abduction. Okay? And they are 4, not 3. Palmar was 3. How to check if it's intact? You abduct against resistance. So basically, you just let's go like this against someone, and they abduct. If you can do this, dorsal is working good. Let's zoom into the picture. See how it's the orange one, by the way. It's connected. It goes up to here, the beginning of the proximal phalanx. Yeah, it helps with the abduction. Abduction, and they're usually like that. It's between the first and the fourth digits, like or spaces. Yeah, here's the first between the thumb and the index, and then the second, the third, and the fourth. Cool. And now we have lumbricals. They come from tendon, go to tendon. Clearly, tendon to a tendon. They're 4 in total. They originate from the what is it? Flexor digitorum profundus or something. Anyways, the function, it flexes the metacarpophalangeal joint. Here it is. This is flexed. And it extends the proximal and distal interphalangeal joints. So these two are extended, and the metacarpophalangeal is, it's what, guys? It's flexed. Okay? Okay. Then you have innervation. Lumbricals 1 and 2 by median nerve, 3 and 4 by ulnar nerve. Lumbricals are over here. Let me get this picture, it's better. Here, 1 and 2 by median nerve. So like imagine it's going through the canal's median nerve over here. Cool? 3 and 4 by ulnar nerve. So just know that the first and the second ones are by median nerve, 3 and 4 ulnar nerve, and it's according to the position themselves. So if you, for example, see your hands like anatomically, the first digit and the second digit are by they're medial, so it's the median nerve, and then the ones far away are ulnar nerve because they're lateral. I think we already took that. Oh my god, guys, I think we're almost done with the bones. We have scaphoid fracture. Scaphoid, remember the mnemonic I told you, Loa, Sam likes to play the tiny cat, hisses, whatever. It's the most common fracture. It occurs in narrow ways between the proximal and distal ends of the bone. Avascular necrosis may occur. Avascular means no blood. Avascular. Necrosis, death of the bone. Okay? Okay. So actually, it's especially in the proximal end because blood supply is transmitted via the distal. No union also occurs. Bones don't join back. Basically, what we're trying to say, all this yap is to say these 3 lines. The scaphoid bone has the median nerve involvement, affects the median nerve. Fracture of it will affect the median nerve. Fracture of the hamate, like we said up, it's an ulnar nerve involvement. Dislocation, most common dislocation is lunate. Most common fracture is scaphoid. You should know the difference between the two. Lunate is median nerve involvement as well. Remember this picture? We said scaphoid will affect the, because it's near the radius. So it's median nerve involvement. And we said the hamate is towards the out, so it's ulnar nerve. Cool? Cool. Yeah. And lunate as well is towards the radius system. And this is just a semi tables I made, so it's easier for you guys to understand what I'm talking about. And these are some radiology slides that I sincerely, generally did not know where to include, but here they are. And then muscles. Let's get back to the muscles of the upper limb. We have back, pectoral, shoulder, neck, and the intermuscular spaces. Let's take it one at a time. The back. We have 5 back muscles. They're super easy, hella simple. طبعا I divided this by wet lab or dry lab, wet lab, and histo. So first we're done with the bones, which is dry, and now back. Since this slide, it's wet lab started. Okay, okay. Now back. We have superficial. We have deep. You don't have to know the difference, but just know the muscles themselves. Superficial, you have the trapezius, which has 3 parts. We'll discuss later. And you have latissimus dorsi. And the deep, you have levator scapula, rhomboid major, rhomboid minor. Let's look at this beautiful picture. So this thing, it looks like it. Yeah, there's a continuation on the other side. This is the trapezius. And then latissimus dorsi is the part under it. It's like that. And then rhomboid major. So over here it's big. And the minor is on top of the major, because minor usually comes on top. And then you have the levator scapularis, which is over here. Don't mix it with the neck. It's a back. Cool. Cool. And it's superficial and deep. Clearly it's divided. Like these are the things you see superficially, and then remove them to see the deep ones. Let's start with trapezius. We said it's divided into 3 parts. We have upper fibers, lower fibers, and middle fibers. Let's zoom into the picture. Upper fibers over here. This is like upper fibers. middle fibers, and lower fibers. Upper elevates the scapula, and it assists an upward rotation like shrugging, because upper, so it raises the scapula. Middle retracts the scapula as pull it towards the spine, so it's like that. Cool? Cool. I hope you're seeing me, like, I don't know. And lower fibers depresses the scapula. Cool? Cool. It's innervated by the spinal accessory nerve or cranial nerve 11. I don't think you took the cranial nerves yet, guys, so low-key just know the name of the thing, if you want to memorize it as well. Wet labs is the trapezius, but yeah, trapezius muscle. And latissimus dorsi is under here, which we'll get into right now. Latissimus dorsi. It's for extension, adduction, and medial rotation of the arms. Extension, adduction, and medial rotation of the arms, right? It's attached to the intertubercle groove over here. Latissimus dorsi. Imagine, okay, so it since starts here, so this is solid, so it pulls this towards the white part. So this will cause the arm to go to the back and more to the medial, so it's adduction and then extend. Because when you do this, it's, I'm pointing with my finger. If you do this, the arms extend, right? Like, pull it, okay, like this is it. Pull it, and it's just like, okay, guys, I don't think you're seeing the vision, but just know it's extension, adduction, and medial rotation of the arms. And it attaches to the intertubercle groove over here. Cool? Cool. And this is something I found, and I don't know what it says. Lady between two majors. So it's latissimus dorsi inserts between the teres major and the pectoralis major at the intertubercle groove. So the latissimus is between two majors, the intertubercle groove, and it's between the pectoralis major and the teres major. We'll get to that later on. And now let's do rhomboid and levator scapular muscles. Levator scapula from the name. Levator as elevates scapula, it's scapula. So it elevates the scapula over here. Pull it, oh my god. So like this. If you pull it towards each other, the scapula gets up. Cool? Cool. Rhomboid muscles. We have major and we have minor. Cool? Cool. Here's the major. Here's the minor. Minor's on top of a major. And they probably do the same thing, which is retracts the scapula. As you could tell, it pulls it towards the medial more. Cool? And here it is on the wet lap. We have the rhomboid major. It's clearly bigger. Minor is smaller. And then levator scapula is on top. So that means the head is oriented like here. Cool? Cool. And now pectoral. We have 4 muscles there. We have pectoralis major. We have pectoralis minor. Also originates from the ribs near the costal cartilages and inserts in the coracoid process. Cool, cool. We have subclavius and we have serratus anterior, which attaches the costal surface of the medial border of the scapula. Cool. Here's more pictures. Pectoralis major. And then we have pectoralis minor. And we have serratus anterior, is the one from the back to the front that goes like that, like that. And we have subclavius, which is under the clavicle, basically. Let's talk pectoralis major first. Pectoralis, the ones in front, they do the flexion. So it flexes, it adducts clearly if you pull this together so the arm gets adducted. And medial rotation of the arm. More pictures. So see here, for example, this is pectoralis major, right? If you pull it towards this beginning of it, the origin, it will be pulled that way. So this arm will move that way. So it's flexion, because it's like flexed, medial rotated, and adducted. So it's added to the, so near the body. And then you have minor. Yeah, it has the protraction of the scapula and the downward rotation of the scapula, and it alleviates the ribs. Look at this. Okay? Okay. Elevates the ribs clearly. Like if you pull these column toward that way, the ribs go up. And on the wet lap, this is the pectoralis minor. And the major is removed. Cool? Cool. Okay, actually, serratus anterior, let me say it now so I don't forget. Long thoracic nerve, was it? I don't know. It's going to be related to brachial plexus. Anyways, we have the deltoid, which abducts, and the deepest teres major. And the rotator cuff muscles are in the shoulder, like we said. We have supraspinatus, infraspinatus, teres minor, subscapularis. I have the muscles, arm muscles, like for the arm, but they originated in the shoulder, like for the arm, but they originated in the shoulder. Biceps brachii and triceps brachii. Awesome, awesome. And this picture, the quality, it's clearly everything is shown. We have the deltoid, which is the one right on top of the shoulder, like over here. And then I have infraspinatus. So imagine, okay, let's imagine this is the scapula over here, right? So I have teres minor. طبعا the humerus, okay. I have teres minor, infraspinatus clearly because this is the spine, supraspinatus over here. This is rhomboid minor, rhomboid major, and levator scapula. Cool? Cool. Cool, guys, cool. Deltoid, cuff, and the rotator cuff and deltoid. So supraspinatus initiates the abduction till 15 degrees. Deltoid abduction after 15 till 90. Infraspinatus is the lateral rotation of the arm. Subscapularis is medial rotation. We already said this before, along with teres minor. This is the lateral rotation of arm. And here it is the same thing, but more pictures I wanted to show you, like subscapularis. Okay. And we said there's triceps and biceps that originate. There are muscles that originate from the shoulder. Cool? Cool. Biceps, as in two heads, because bi, and triceps, that's your head. They're just showing you that, okay, this picture is major, so this is the bicep over here. It's like, that's two heads. One, two. And the triceps, we have the long head of triceps over here. And the lateral head of triceps over here. Like that. Okay. Okay. Okay, thank God we're done. Now neck. Neck is so beautiful and so cute, guys. There's only one muscle that you need to know. It's the easiest muscle you'll ever take through the whole medicine journey. Sternocleidomastoid. I forgot it. Mastoid. Sternum, clavicle, and mastoid. It's basically rotation around the vertical axis. So when you do this one, yeah. So for example, imagine I'm looking this direction. To turn that way, my sternocleidomastoid on. Okay, I'm looking to the right. My left one needs to contract. So I turn left. It's so cute, guys. I love it. I love it. So looking left and right. So basically, the ones that allow you to do this, sternocleidomastoid. And that's all you need to know about it. And now you have intermuscular spaces. You have 3 intermuscular spaces: quadriangular, triangular interval, and triangular space. Triangle, triangle. Let's talk about all of them in details. And I'll show you pictures to make it super easy. For every space, you just need to know the boundaries and what goes through it. Easy. This picture is so cool. It's the girls from our batch, our friends did it, and they made it so easy. But let's start off. Quadriangular space, that means we have 4 boundaries. Let's look at this picture. Okay, so they told us to do this in lab. Imagine you have 2 fingers like this, 2 fingers like this, and you just intertwine them together. So it's like that. Cool? And we have a space down here, a space up here, and a quadriangular space over here. Cool? Cool. This is going to be the surgical neck of humerus. And okay, so you can switch the hands like this and this. If you're using your left, if you're looking for the left humerus, so put the humerus like standing that way. Okay, so it looks like this. If you're using your right, do it this way. Cool? Cool. With the humerus comes the triceps brachii, or the long head of the triceps. Basically, just use triceps. And then the up is going to be teres minor, down is going to be teres major. It's always going to be this way. Up teres minor, lower teres major, up teres minor, lower teres major. Cool? Cool. So, if you're looking in this space, up is going to be teres minor. Down is going to be teres major. 2, laterally, it will be humerus, because humerus is always lateral. Medially, it's going to be the triceps. Cool? Cool. I hope that made sense. It took me the whole last year to understand it, but it was very cute when I learned it. Okay? Surgical neck of humerus, teres major, teres minor. What goes through this quadriangular space? Like I told you, they always come together. Posterior circumflex humeral artery and the axillary nerve. Because we said there's surgical neck of humerus, so surgical neck reminds you of axillary nerve. What comes with axillary nerve? Posterior circumflex humeral artery. Easy? Easy. Cool. Cool. We have triangular space. Triangle. So just 3 this time. Over here. This is the one. Cool. And the space, let's say no, يعني, triangular space is more like longer. Interval is like shorter but thicker type thing. Okay, do it again. This is the interval, or the space, I'm sorry. Same thing. This was the triceps, so this time the lateral will be the triceps. Or sorry, oh yeah, I'm holding it. Lateral would be triceps. Up would be teres minor, down would be teres major. Superior teres minor, inferior teres major. Lateral, long head of triceps. Cool. And here the circumflex scapular artery goes through the space. Over here, it goes to provide, like, think of it, it's going this way for the scapula, so it would be the circumflex scapular artery. Awesome. And finally, the interval. It's also triangular, so it's 3. It's the one down this time. So do it. It's the one here. It would be laterally, humeral head, or humerus in general. Tamam? Medially, you have the triceps, this one. Superiorly, you have the teres major. Don't mix it up, guys. Wallah, it's super simple when you start seeing what I'm talking about. Like, it took me so long to figure it out. Superior, lateral, and medial. The radial nerve and the deep brachial artery go through it. Like we said, radial comes with deep brachial artery. Cool? Cool. Axillary is quadriangular space, has the axillary nerve and the posterior circumflex artery, because laterally you have the surgical head of humerus. Awesome? Cool. 1 second. No, I messed it up. I'm so sorry. I'm so sorry. I'm so sorry. That's on me, guys. Wallah, this was on me. So this is the humerus, right? And then you start the triceps. Like I said, the triceps has like 3 heads. And then this is the teres major. So superiorly is teres major, yes. But laterally and medially over here, down here, it's going to be the heads of the triceps, not the humerus. So lateral is head of triceps, and medially is also head of triceps. Cool? I'm so sorry. That's on me, guys. So sorry. So sorry. Profunda brachiae, as in profunda means deep also. So it's profunda brachiae artery or deep brachial artery. Cool. Let's continue. This is on the wet lap. Guys, tell me this is not the best picture you've seen in your life. Because if you say it's the best one, I'm gonna call you a liar. We have a triangular space, triangular interval, triceps longer. The thing is, in everything, we learned it in the humerus. But realistically speaking, it is the heads of the triceps. So, learn. Anyways, your favorite and my favorite and everyone's favorite, the brachial plexus. Thank God for OSPE, you just need to know one point and one point alone, which is the M, guys. The M over here. Boom, boom, boom. The M. Medial to lateral, medial is ulnar, then medial, then musculocutaneous. Posterior cord, medial to lateral, has radial and axillary. Cool? Cool. So axillary and radial. Radial is more medial. Axillary is more lateral. Musculocutaneous is lateral. Medial, median is in the middle. This is median, not medial. And we have the ulnar one. Cool. Also, one of the questions that I didn't put here, صراحة, but I'm assuming in one of the questions could be like, oh, like they would circle or put a pin on something and be like, what is this? For example, let's say it's the median nerve. They put a pin and they're like, what is this nerve? They could ask you, for example, name something it supplies or name a structure it goes through. So they like, oh, median nerve goes through the. They could also be like, name the roots that this come from or the trunk it comes from or the origin of it. So you have to know where each one comes from. And this is the whole Dr. Vlad's lecture. It's not OSPE. It's like, I'm just saying it could come. Anyways, if they get you the M, just know how you're looking at, like what structure you're looking at. Is it the ulnar, median, musculocutaneous? Posteriorly, is it the axillary or the radial? You get it. You get the hang of it. Cool? Cool, cool. Same, here's another M. So you have this is the lateral cord, musculocutaneous is over here. Median nerve, ulnar nerve, so it's an M. Cool? Cool. Lateral is musculocutaneous. Middle strand is the median. The medial is the ulnar nerve. Cool. Cool, cool. Another picture. M. Lateral is musculocutaneous, middle is median, medial is ulnar. So like the one most medial is the ulnar. The one in between both of them is the median, and the lateral one is musculocutaneous. And that's it for brachial plexus that you need to know for OSPE. Cubital fossa, guys. Cubital fossa, it's basically in your elbow over here, like this sports, right? It has borders and it has structures going through it. Let's start with the borders. You have superiorly, it's the line that connects the two epicondyles. Medially, you have the pronator teres muscle. Laterally, you have the brachioradialis. There's no comeback from this, guys. You have to memorize this. Floor, you'll have the brachialis or the supinator. Roof will be bicipital aponeurosis. And I think that's middle yet. So yeah, we did the top. It's like a pizza shape. So same, 3 borders, and a floor and a roof. Cool, cool. The structures that go through the cubital fossa is, like we said, it's MBBS, which is the thing we're learning right now. M, median nerve. B, brachial artery. B, bicipital tendon. S is the superficial branch of the radial nerve. And you guys have to know all this. It's very simple. Like median nerve, brachial artery, there's a nerve and an artery and a tendon. And the branch of a nerve and another nerve. So it's the median nerve and the superficial branch of the radial nerve. And you have the brachial artery and the bicipital tendon. And I think this is also in a specific order. So it's medial to lateral. Hi, it's a table that summarizes the cubital fossa. Medial is pronator teres, lateral brachioradialis, superior is the line connecting floor is brachialis and supinator. Roof is the bicipital aponeurosis. Contents is MBBS. Medial to lateral, median nerve, brachial artery, biceps tendon, and radial nerve. Okay, upper limb flexors. Basically, I mean the forearm. It's the big boss. Let's start off with strong and easy. Biceps brachii. Up. Biceps means it has 2 heads. And since we said it's flexor, so it does what? Flexion at the elbow because it's up, so it's flexion. And then it's innervated by musculocutaneous nerve because flexors in your arm is musculocutaneous. That's different from the ones in your forearm, which we'll get to. And then you have the brachioradialis, which holds the radius together in the Colles fraction. It also does flexion at the elbow, but this one is innervated by the radial nerve. Radialis, radial nerve. Just try to connect it somehow, guys. MSK is all about connection. Okay? Okay. We have the brachioradialis over here, which is like basically. Okay, so where is the radius is lateral. You're gonna find it connecting your arm to the down there. So it's both in the arm and the forearm. Cool, cool. And on the biceps, I didn't show you. I showed you before it's there. Flexors of the forearm. Forearm, you have 3 layers. You have superficial, intermediate, and deep. Let's start off with superficial layer. The same beautiful thing that people do. It's which you place your fingers like that, and that should tell you your middle finger should be going to the middle of your hand here because this is palmaris longus, which we'll talk about. So it should look like something like that. You start off with pronator teres, flexor carpi radialis. Palmaris longus, flexor carpi ulnaris, because you're moving from lateral to medial. So ulnar is medial, radius is lateral. Awesome. Awesome. Easier picture. Pass fail, pass fail. You have pronator teres, flexor carpi radialis. Palmaris longus, flexor carpi ulnaris. You just have to memorize, I guess. Let's go through each. Pronator teres, pronates. And it's flexing, because we said the flexors of the forearm. So, flexors of forearm are flexed by the median nerve. Flexors of the arm are by musculocutaneous. Cool? Cool. And just when you look at the hand itself, when they show it in real life, look which one is, like, where's the thumb located? Thumb is most lateral. So, ulnaris is medial, and pronator teres is lateral, and then the radius bone is over here, and so on. Cool? Then you have flexor carpi radialis. It's flexion of the wrist. It's innervated by the median nerve. Again, it's the one under the flexor carpi or pronator teres, flexor carpi radialis. See the thumb? You have the radialis and you have pronator teres right beside it here. 1, 2, 3, 4. 1, 2, 3, 4. Awesome, awesome. And this is medial side, lateral side, so it's more on the lateral side. Above it is the pronator teres. You have palmaris longus, which is literally the what's so special about it is not it's the fact that it's not in everyone. Like not everyone has it. It's like a palmaris longus is the one that goes over here. It's like this one. Like when you flex your hands, it's like this one. Anyway, yeah, it's again innervated by median nerve, and it's a flexion of the wrist and tension of the palmar aponeurosis, which is over here. Cool. And I have carpi ulnaris, flexor carpi ulnaris. So it flexes and it's innervated by ulnar nerve. That's the difference. Because when you go medially, like we said, we have two flexors or two nerves that flex. We have median, which is for everything lateral, and the ones medial are ulnar because it's related to the ulnar, which is more medial. Just try to memorize it in a random way. This is extensor. I don't know why I put this here, but just know this wet lab is wrong. But here's the flexor carpi ulnaris. It's most median. Type. We're done with superficial. We had PF, PF, superficial. Let's go to intermediate. We have just one, just flexor digitorum superficialis. Superficial, so it flexes the proximal joints. And the metacarpophalangeal, and it's innervated by median nerve because it's more here, right? Superficialis. You'll find it's in the middle, like we have 3 layers, right? And then now the third layer, which is the deep layer, you have flexor digitorum profundus. Profundus means deep. So if you have the one that's superficial, you'll find the one that's profundus. It's flexion of the distal back. So the ones that are intermediate is for proximal and metacarpophalangeal, and the ones that are deep are for the distal. Distal deep. Cool, cool. Innervated by median nerve and ulnar nerve. Both of them. It's crazy, guys. Wow. Look at this. Look at this. So beautiful. This picture is so beautiful, guys. So palmaris longus, which is superficial. You have flexor digitorum superficialis intermediate, and flexor digitorum fundus, which is deep. Pronator quadratus and flexor pollicis longus. Pollicis longus, we said this is thinner muscle. We have pronator quadratus, pronator, so it pronates the forearm. Okay, it's over here. You have the flexor pollicis longus, flexes the thumb, pollicis, at the interphalangeal joint. Both of them are supplied by the median nerve anterior interosus. Preferably right the long thing, like median nerve anterior interosus, also which is medial. Okay. Flexor pollicis and pronator quadratus. Cool. And this is the doctor put for you. He has the muscle, the proximal attachment, distal attachment, innervation, and main action. I suggest go through it, summarizes everything. So at least if you like are hesitant or what to write to exam, you can write anything on these. And now extensors. Flexors are on this side, extensors are on the dorsal side. We have again superficial and deep layer. While flexors, we have superficial, intermediate, and deep. Let's start with the superficial layer. I have extensor, carpi radialis, longus, and brevis. So it's innervated by radial nerve because extensors are by radial nerve, and it's posterior interosus nerve because it's on the posterior side of the hand, and it causes the extension and the abduction of the hand. Cool? Cool. Okay. How do I help you connect this? Okay, extensor. So from the name, it extends. Radialis is lateral because radius is lateral. So lateral is more away from the body, so it takes away, so it's abduction. I hope that. So it's like this. Your hands goes like that. I'm trying to connect it to you as much as possible. Like I'm trying to make it so silly that you remember it. Extensor digitorum, it's innervated by the radial nerve, posterior interosus as well. It extends the digits at the metacarpophalangeal, except the pinky, because the other one's called digiti minimi. So extensor digitorum, it basically extends the fingers, or the digits, at the metacarpophalangeal. Right? Over here, you'll find it in a place where it can extend everything. Extensor digitorum. Okay? Digiti minimi. You'll literally find it going to the pinky, because it's for the pinky. Same thing, radial posterior interosus nerve, but it extends only the pinky at the metacarpal junction. So all four of them are extensor digitorum, and the pinky is extensor digiti minimi. And all of this superficial layer. So you'll see it easily. You don't even have to dig through other muscles to see. And the carpi ulnaris radial nerve posterior interosus is over here. It will be more medial than, okay. So you see how the digiti minimi is the last thing because it's going to the pinky? The one above it immediately is going to be the extensor carpi ulnaris. And that's the picture, I added it here. Okay? Over here, it's going, so one under it over here, it's going to the pinky, it's the digiti minimi, and then over here is the extensor carpi radialis. Ulnaris, my bad. Awesome. So it goes to extension and abduction of the arm. Should be fine. This is just a recap of everything together. So this is the, oh my god, the quality is, okay, extensor digitorum. Hell, you have more extensor digitorum. I don't know why it's labeled that way. Okay, you have the extensor carpi radialis brevis and longus. So one, oh my god, one of them has a long, and one of them is brevis, which is shorter and thicker. Longus is longer and thinner. Hope that help you guys somehow. So basically, superficial layers say you have four. 1, 2, 3, 4. You have radial, ulnar, digiti minimi, and digitorum. All this is for the extensor, superficial layer. Deep layer, as we have deep extensions of the forearm, we have these ones. All of them attached to the thumb except the extensor and indicis. And okay, guys, bear with me on the pronunciation. I'm so sorry. We have supinator, extensor, indicius. Oh my god. Abductor pollicis longus, extensor pollicis longus, and extensor pollicis brevis. Okay? Okay. Most of them are by posterior interosus nerve, except the supinator, which is deep branch of the radial nerve. It's a deep branch. Cool, cool. Supinator, it supinates the forearm. Extensor incidus, it extends the second finger, which is the index finger. You have the abductor pollicis longus, abducts the thumb. Extensor pollicis longus extends the thumb. Extensor pollicis brevis extends the thumb as well. Both of them at the carpometacarpal and the metacarpophalangeal joints. Except this one, pollicis longus is at the interphalangeal joints as well. Cool, cool. This is the abductor pollicis longus. It goes to here, it abducts. So if you pull it, so if it pulls that way, the finger will go that way, so it's abducted. Okay, and there's just some things. Extensor pollicis brevis is the small one. Okay, let me change the color so you can see. It's the small one, the brevis. And then the abductor pollicis longus goes all the way to the thumb as well. And then you have the extensor incidus goes to the index finger. And extensor pollicis longus goes exactly where the other brevis one goes. Just extend. Cool. Here's again the neurovasculature of the forearm, which is just like a recap of everything important to go on. You have the median nerve with the brachial artery, they come together. Sure, the fossa, whatever. And then you have the median nerve, continue. And then you have on the ulnar side, you'll have the ulnar nerve and artery together. And you'll have the radial artery going on here. You have the anterior interosus nerve. And then you have the deep palmar arch and the superficial palmar arch, which I'll explain in the coming slides. But yeah, cool. Another picture, you have the radial artery, the pronator teres muscle, superficial radial nerve. Radial artery comes with the radial nerve, and you have the deep branch of radial nerve is on top here. Brachioradialis, recurrent interosus, posterior interosus. And this is the nerve, posterior interosus. Okay. Now, we're going to be talking about the blood supply of the head. And we're almost there. Wallah, we're almost there. Blood supply of the head, you have two arches that you need to know about. You have superficial palmar arch, you have the deep palmar arch. Ignore the arteries for now. Let's talk about the superficial palmar arch. See these pictures? Look at them right now. And look at this. This has common palmar digital split into proper digital. This has palmar metacarpal joined with the common palmar digital, right? Right. I'm going to respectfully ignore everything and just come here. I'll draw you something. So first of all, you start. Imagine you have a hand right now. First of all, the ulnar artery comes. Okay? You're going to have that deep branch over here. And then you have the superficial branch. Superficial branch will make something called an arch. And we'll stop there. And then it will give some branches off. Let's do this right now. Okay? Okay. Let's say these are the common digital arteries. Then you'll have the proper digital. طبعا it goes supplies like here. All everything, like common digital and proper digital arteries or whatever. Cool? Cool. This is for the ulnar arch. And this is the superficial branch. And now, you're gonna have the radial arch. What is this radial artery gonna do? It's gonna join the hand, and it's gonna, I think, it also has another branch coming off, and it would have a superior branch. Cool? This superior branch is gonna join with the ulnar one, and this other branch is gonna form like a loop, and it's under. Yani this is the layer that's under this one. And it's gonna go join that deep branch of the ulnar. It's the radial. Okay? So the black one is the superficial arch. The blue one is the deep arch. Cool? Cool. What's so special about the radial? It's gonna give, or the deep palmar arch, I mean, it's gonna give two branches. First branch is gonna go to the thumb, and it's called the principal pollicis artery, and the other one is gonna go to the index, and it's called the radialis okay, I don't know how to pronounce that word, guys. Indicis? Bear with me, it's indicis. Cool? Cool. I hate the drawing I did, but this is basically just to show you how the two arms form. So radial is basically this one, it forms the deep, and the ulnar goes, this one forms the superficial. And it gives common that give proper. Cool? Cool. Also delete this, I think this one I drew it by accident. It's basically like this forms here and here, here and here, here and here. Cool? Let me clean this up for a bit. It's gonna go like this, this. Cool? I hope this made it easier, because now we're gonna take the real life pictures. Cool? Cool. So, superficial palmar arch give you the common, which split into the proper digital arch. Also, proper, or the common goes into proper. Okay? Okay. And just know it's radial plus ulnar, but mostly ulnar. And then deep, it joins with the common palmar digital artery, and it gives you one for the thumb and one for the index finger. Let's speak. Now, ulnar artery. It's the main contributor to the superficial palmar arch. The branch joins with the radial artery to form the superficial palmar arch. The deep branch helps to form the deep palmar arch. The common palmar digital arteries split into proper palmar digital arteries. See? This is common over here, and gives proper. Common gives proper. Common gives proper. This is the superficial branch, deep branch. Awesome? Awesome. Radial artery does the same thing. We have a superficial, it helps with the superficial palmar joins with the ulnar. It's being contributed to the deep though. Radial over ulnar. It forms the deep palmar arch, which gives the princeps pollicis artery, which supplies the thumb, and the radialis indicis, but the one that goes to the index, which supplies the lateral side of the index finger. Awesome. Awesome. So basically one of them here is the radial. It goes here from the deep arch. It supplies this and supplies the lateral of the index. Easy. Easy. And here are extra pictures from the wet lab that I sincerely didn't know where to put, but I wanted to put them for the sake of completion. Anyways, so you have the abductor pollicis brevis, abductor the thumb, abductor pollicis longus. Cool? Between the thumb and the finger, we've got the first dorsal interosus muscle, which abducts the index. Awesome. These are just some things that students captured for their own help, but I just wanted to put for the sake of completion. Opponens pollicis goes to supply the thumb from here, so it does the opponent's thing. I think these should be more clean. So we said this tendon is going to cause flexion, so it's flexor pollicis longus. Girl. Muscle attached in the linear fashion is opponens digiti minimi and digital minimi. Yeah, so this is the pinky, so it has the digiti minimi. And we said the flexor carpi ulnaris, it's identified by its insertion point. Abductor digiti minimi, so that means we're in the pinky, so it's the most medial. So we have the flexor carpi ulnaris given, and under it would be the flexor digiti minimi. And I have great news for you guys. I think you already took a sneak peek. It's time for histo. What? Yeah. Okay. Let's start with the simple one. Skeletal muscle. Skeletal muscle. Yeah. Okay. First of all, I want to say something about histo. Histo, the pictures they put in the PowerPoint, copy paste are the picture that they come or get you in the exam. So if I were you, I would low-key just open the histo slides that Dr. Shad and Dr. Inas and all the doctors sent, and I'll just look at the picture and be like, yeah, this label here stands for this, so that means this is this. Okay, so just memorize the picture. Here, I'm just for the sake of making the memorization easier. But honestly, this is a you job. I think it's easy. I don't think you should stress too much about histo, inshallah. Like, they're giving you the slides, easy more. Let's start with the skeleton. Skeletal muscle, you can see it's multinucleated. See these two slides? I got all the slides from your PowerPoint, by the way. Anyways, so you have multinucleated. It's long fibers. It has myofibrils, striations, which are these like lines over here. And there's A bands and I bands. Okay, let's look at this first. This is a combination of the longitudinal section and transverse section, and they took each differently. So if you can see the peripheral nucleus, that means you're in transverse section. And as well, here's peripheral nuclei in the longitudinal section. There's fibroblasts. Yeah, I'm trying to think of the things they're gonna ask. So on I bands are the whitish ones, A bands are the darker ones. Cool? Cool. Striations, multinucleated muscle fiber and peripheral nuclei. Here, skeletal muscle, we have three layers. We have epimysium, perimysium, and endomysium. Endo is inside, peri around each vesicle, and epi is entire the whole muscle. It's dense irregular. So I don't know if they could get you this picture. Honestly, it's like epi and then peri and then another epi because you can't see the endo, but the endo is like anyway. And yeah, here's the epimysium. Yeah. This is a better picture. This is such a cute picture. So FC is a fascicle. Fascicle. So around each fascicle over here, you'd have a perimysium. Around all of this, you'd have an epimysium, which is over here. This is an epimysium. Perimysium is around each fascicle. Cool? Endomysium is around each one alone. Cool? Each muscle cell or fiber. I hope that was easy. This one, honest to God, I did not find in your slides. But I put it because it's very important and I think it came multiple times before. And it's very easy. You see dark, like when they show you these things, you have two types. You have darker type and the lighter type. Type 1 of skeleton and type 2. Cool? Type 2 is lighter, yeah. Type 1 is darker. Why is it darker? Because of the myoglobin. So it's darker because it has high myoglobin and low glycogen. Lighter because it has lower myoglobin, but it's higher glycogen. That's literally all you have to know. This is the models themselves in the lab. Highly doubt it's gonna come on the muscles because what? But I put it just for the sake that you can visualize what's going on, like striations are here. And then you have another muscle or another model where you can see the I bands, H bands. So we said darker is I band, A band, and lighter is I band. And Z line is the connection between the I band, or something like that. Awesome. Awesome. Cartilage, guys. We have three types of cartilage: hyaline, elastic, and fiber cartilage. Let's talk about hyaline first. Hyaline is usually found in trachea, and if they get you a slide, it's gonna be this slide, this beautiful, beautiful slide, printed or something. You have to know that hyaline is type 2 collagen. You have chondroblasts, chondrocytes, and طبعا perichondrium, which surrounds everything. You have perichondrium over here, which is divided into two. You have inner cellular because it has all the cells, and outer fibrous for protection. طبعا it's in the trachea. It's pink and purple. It's a really cute slide. You have chondroblasts, which is on the periphery. Over here. Let's say blast is for beginning, right? So this starts and then becomes chondrocytes, groups of up to 8. It's in and around the lectin. Okay. Perichondrium, we said inner cellular, outer fibers. Okay. That's all you have to know. You have to know this is interterritorial, and the openings themselves are territorial matrix. Easy. So it's collagen type 2. You have fibroblast. You have two types or two layers of the perichondrium. Pink one is outer fibrous. Purplish one is inner cellular. Then you have chondroblasts in here, and then they'll start dividing, becoming chondrocytes. And we're done with hyaline. Elastic. Elastic you can find it in two places, air pinna and epiglottis. And I think they would probably get you the epiglottis one, but for now let's focus on both of them for sake and know what if they don't. We said all elastic cartilage is surrounded by perichondrium as well, outer fibers, inner cellular. Elastic cartilage is composed of extracellular matrix, which is the same as hyaline cartilage because hyaline has extracellular matrix. But it also has elastic fibers as an addition. It has two types of cell, chondroblasts on the periphery, chondrocytes in and around the lacuna. Same thing. This one looks very like it has so many trypophobia like alerts or whatever going on. Anyways, this is the air pinna, and it shows the perichondrium, which is outer fibrous, inner cellular. Chondroblast on the periphery becomes chondrocytes in the lacuna. On another perichondrium. Elastic epiglottis. It's very bluish, purplish, dark stained. So we said elastic epiglottis are darkly stained in preparation with special stain. Elastic fibers, which like the yellow arrow over here, surrounding the chondrocytes. Outer fibers, inner cellular perichondrium containing chondroblasts. So the perichondrium as well got the chondroblast in the periphery, chondrocytes in the lacuna, same thing. Darker stain is probably epiglottis, and it's elastic. This one is like forming a lot of trypophobia things. It's also elastic, but it's in the ear pinna. And hyaline is JK. You have to have known this slide since CVP, guys. Like it's the same slide. And then the last type of cartilage we have is the fiber cartilage. We can find an intervertebral disc. Here's just something I put. I don't think you should even focus on the slide, but I was just saying an intervertebral disc is composed of two, has the pulpus and the fibrosis. And we're going to be talking about the fibrosis one is outer ring of the disc composed of fiber cartilage. So the fibrosis has fiber cartilage. And what, from the name, what makes the fiber cartilage very special? The fibro, it has fibers. The elastic has elastic, and hyaline doesn't have either. Okay? Okay. And then annulus pulpus is gel-like material, which has like it's rich proteoglycan and water. See the slide? We're basically just going to zoom in. Just know that this is the nucleus pulpus and the fibrosis over here, which is the one we're going to be discussing. Cool? Cool. Zoom in. Fibroblasts, elongated under spindle shape. It has collagen type 1 and collagen type 2. Type 1 is for strength and flexibility. And then type 2 is the collagen, like, and the hyaline and everything else. And they have chondrocytes. Just look at the picture. We have chondrocytes, which is inside the lamina, bundle of collagen type 1, fibroblasts, and this is all in annulus fibrosis. So if they get you the slide, just know it's an intervertebral disc. It has fibrocartilage. What makes it special? It has collagen type 1, type 2, and yeah, we're done with cartilage. It seemed very simple, alhamdulillah, because all you have to do is just look at the slide and be like, elastic hyaline fibrocartilage. Should be easy, inshallah. Parathyroid, my favorite thing ever, my baby for you. I love parathyroid gland, guys. See, that's all I have to know about parathyroid. Two colors, purple, pink, and white is adipose tissue. Cool, so it's basically fat. Purple, important, so chief cells. It helps secrete parathyroid hormone, increases blood calcium levels. Easy, easy. Oxphil is pink. We don't know what the function is. Cool. Cool. Big part. Bone, we have two things we're going to discuss in bone. We have cortical bone or compact bone, which is 80% of the total bone mass. We have trabecular bone, which is cancellous or spongy bone, which is 20% of the total bone mass. So if you're looking at these things, we have the cortical is the strong part, trabecular is the spongy part. Spongy part, strong part. Spongy part, strong part. Cool? Cool. Let's start talking about the compact bone. First of all, outer layer of anything is called, of the bone is called periosteum. Cool? Cool. It's basically articulation with other bones, there's cartilage, but the outer bone of outer layer of any bone is a periosteum. Inside surface is endosteum. We don't want to know about this. Let's go in details about periosteum. Periosteum is divided into outer fibrous, inner cellular. Outer fibrous resembles other dense connective tissue. Inner cellular contains the osteoprogenitor cells, which is like the start of all the other cells that come out. Inner cellular layer is the thick and outer collagen fibers are arranged in parallel to surface of the bone to form a capsule. We said the osteocytes are located inside the lacuna. Don't care about all this. Let's focus on the slide because that's what's important in histology. Periosteum, you have the fibrous layer, cellular layer. Cool, cool. OP, osteoprogenitor cells. OC, osteocytes. BV is blood vessel. And this is it, guys. This is literally it for the slide. Just have to know what is going on. Let's talk more detailed or the lamina of the compact bone. We have important structures that we need to focus about. First of all, we have something called concentric lamina, which forms the osteones. We have a Haversian canal, which is also called central canal. We have Volkmann canal, which connects the Haversian canals to each other so they can communicate. And lacuna has the osteocytes. Let's see how this is. They could get you this, which will just basically be like periosteum, outer layer, Volkmann canal, Volkmann canal. Basically, any connection between two things looks like any circle is like osteone. There we go. Osteone. Osteone. Cool? Cool. CC is the Haversian canal. So it's basically you have an osteone, right? It's like this. The central one is the Haversian canal or the central canal. Cool? Cool. Same here. So many things going on, but literally it's the same thing repeated. So connection between things, Volkmann canal. CC, Haversian canal or central canal. Big circle, osteone. So just know that this is an osteone, the big circle. Central canal, Volkmann canal connects the Haversian systems together. So it's blood vessel and bone elements. Mature cortical bone is largely composed of cylindrical called Haversian system osteone. Lacuna is interconnected by caniculi. Next. This is the same thing, but it's a different cut, shape, color, everything. Central canal, Haversian, Volkmann canal connects them together. CLC is basically the, I want to say this, the caniculi connects them together. Lacuna, and yeah. Other elements and everything. Cool. Trabecular bone or the spongy bone, you can find it mostly in the axial skeletons, in the epiphysis and metaphysis of the long bone. It literally looks like something, like, I don't like looking at things like this. It's just so weird, like a lot of zigzags together, whatever. So T is trabecular, B, sure. And finally, if you look at the toe joint, it has trabecular bone. Something special about it, it has no osteones. Cool, cool. Things we're going to look at are osteoblast, osteocyte, trabecula, and bone marrow. House shaped lacuna, which contains the osteoclasts. Cells are essential for bone matrix. So I'm going to assume that this is the lacunas. This is the house-shaped lacuna. Okay. Let's zoom in a little bit. Cool? Cool. OC, osteocytes, they're in the lacuna. OCL, I'm going to say that's osteoclasts. And OB, they're on the periphery, so they're osteoblasts. Osteoblasts built, osteoclasts break. Cool, cool. Osteocytes are the things that transform into them later on. Cool. So osteoblasts, osteocytes, osteoclasts, they're big. And yeah, this is the slide. Like, you should know the slide because I think they're gonna get you zoomed out and then they're gonna be like zoomed. So if they get it, it's gonna be like this, all three layers of the picture. Okay. So don't worry about it. Just memorize what each thing stands for. And this is the model that is found in your slides. So if you could see that this is the artery, around it is the, okay, it's interstitial lamina. Lamina. Remember this thing that was up? Yeah, it's interstitial lamina. My bad, guys. Osteons is the circles, and Haversian canal. You have the Volkmann canal, which connects them together. Haversian canal is the one that's like in the middle of the osteon over here. Cool. Perosteum is the outer line. And I put you these tables, which summarize everything, everything, something important about each thing. So if you just need to recognize the slide. When you recognize the slide, remember these tables because they tell you what's so important about it, what fibers it has, a common site it's found, so on. So skeletal, for example, striated multinuclear hyaline, perichondrium is present. This is hyaline but elastic. So a fibrocartilage is thick collagen. It has type 1 mainly, but it also has 1 plus 2. Hyaline is type 2. Elastic cartilage is type 2 plus elastic fibers. You see? This is in the trachea. This is in patella and epiglottis. This is in the intervertebral disc. Compact bone is the shaft. The trabecular is epiphysis and metaphysis. This has osteoblast, osteocyte, osteoclast. Compact bone only has osteocytes. And the difference between compact bone and trabecular bone. So this is cortical, this is spongy. This has osteons, this has trabecular, no osteons. This has a virgin canal, this doesn't show them. This is in the diaphysis, this is epiphysis, this is the metaphysis, axioskeleton. The marrow spaces here is less obvious, here it's more prominent. And how you'll point, this has concentric lamella, this one has no osteons. Easy, easy. With that, I can say we're officially done with the upper limb and histo of this part of history. But what I can tell you guys is good luck. Wallahi, MSK got nothing on you. It's inshallah gonna be super easy. I know it's dense and we spoke for so long and you're gonna speak for longer in the lower limb. But this is basically just like the night revision of everything that you took in MSK. Good luck. MSK is easy. Someone told me before it's called Khitamuha Misk. So inshallah you're ending this semester on a good note. Without further ado, I'll pass the mic to Ibrahim so he can speak with the lower limb and histology. Bye guys, goodbye.
Okay, assalamu alaikum everyone. My name is Ebraheem Hoda, a second year medical student, and I'll be giving you guys the second half of this OSPE crash course. Um, I'll be teaching you guys the other half of histology, as well as the anatomy of the lower limb, and I'll be going over your physio lab as well. Inshallah, this should not take that much time. Hopefully, by now, you guys have a good grasp of everything that's going to come in the exam. And if you guys have any questions, feel free to text me anytime. I'll be more than happy to answer. And with that, let's get straight into it, starting off with ossification. So we're going to start with ossification, which is basically how our bone is formed. There's two main types of ossification that you guys should know. There's your endochondral and intramembranous ossification. Starting off with endochondral ossification. So this slide over here, you can see your endochondral ossification. This is taken from your toe or finger joint. Endochondral basically means within the cartilage. So in this type of bone, in this type of ossification, the bone is typically formed by replacing your cartilage, okay? So you have five main zones. You have your zone of reserve cartilage, you have your zone of proliferation, you have your zone of hypertrophy, you have your zone of calcified cartilage, and you have your zone of resorption, which is your zone of ossification. You could think of it like that. Simple mnemonic that that I put over here in case you guys want something to remember. Real people have crazy ribs. R for reserve, P for proliferation, H for hypertrophy, C for calcified cartilage, and R again for resorption. Okay, let's take each of these one by one, starting off with the first zone, which is our zone of reserve cartilage. Okay, this zone of reserve cartilage is sometimes called your resting zone. Over here, your cells are small, they're round, and they're scattered randomly, and there's no active cell division that takes place here. Think of this zone as like a storage zone, okay? You have no active matrix production. The cells over here, basically the cells over here are few, so there's low density of cells, and there's abundant extracellular matrix that surrounds each of these cells. You can see over here, like there's one cell and surrounded by a hella extracellular matrix. Um, Over here, the cells also appear to be small and round, and they're scattered randomly. And keep in mind, these cells are not arranged in columns, okay? That's for the next zone, which is our zone of proliferation, okay? Over here, the cells start to become larger, okay? They're larger than the reserve zone. And the main feature over here is that your cells start to get stacked up in columns, okay? They're stacks, think of them as small stacks of coins. You can see over here, these cells, like basically stacked in coins, stacked like small coins. Over here, the cell starts to divide rapidly, and they also start to secrete type 2 collagen. And keep in mind, again, important thing is that they arrange themselves in columns. Next up, we have our zone of hypertrophy. Hypertrophy, as you guys know by now, is basically enlargement, okay? over here, chondrocytes, which are basically your cells over here, they become greatly enlarged. Okay, they have clear cytoplasm, which basically means the cytoplasm is much paler. If you compare it to the previous slide, the cytoplasm over here is much clearer. Between the chondrocytes, the cartilage matrix starts to get squeezed into thin bands. Over here, you can see it again. This is your cartilage matrix, and it's squeezed into thin bands between the cells. And over here, the cells continue to secrete type 2 collagen. But in addition to this, they also secrete your VEGF. What is VEGF? VEGF is your vasoendothelial growth factor. What it basically does is basically recruits blood vessels to allow for blood supply to the uh, new bone. Okay. Now, zone of calcified cartilage. So over here, uh, things start to die, okay? Your cells start to die because think of it, if you have something that's being calcified, it's not really alive anymore, right? So over here, the cells start to die, and the cartilage matrix becomes calcified. Now, because of this calcification, the cartilage matrix starts to become even darker, okay? So it becomes basophilic compared to the previous slide. So previous slide, as you guys saw, it was very pale. Over here, now it's much darker and more basophilic. Next up is our final zone, which is our zone of resorption. Over here, the chondrocytes are dead. There's no cartilage matrix. The cartilage matrix becomes calcified, and it basically serves as the location where your new bone will start to form. And osteoblasts will start to move in to deposit your osteoid, okay? And blood vessels, due to the VEGF, will start to invade this zone. Now, let's look at this section of histology. So you have your osteoblasts over here. These are your bone building cells. These line your trabeculae. And what these osteoblasts do is that they produce osteoid, which is your basically unmineralized bone, which is laid down by your osteoblast. Um, if In the OSPE, if you see any like plump or round cells, like you can see over here, these round cells, just know that they're your osteoblasts and there's endochondral ossification going on, and osteoid is being laid down, which is your unmineralized bone matrix. Okay. Now, moving on to intramembranous ossification. So this is your second type of ossification, where the bone will directly form from the mesenchymal tissue and there's no cartilage template that is needed, okay? So in your endochondral ossification, you needed a cartilage template upon which the bone is built upon. But over here, you have intramembranous ossification. There's no need for that cartilage, and there's direct formation of bone from the mesenchymal tissue. So you'll have your mesenchymal cells. Over here, you see M over here is your mesenchymal cells. Your OB is your osteoblasts, which are, again, you can see these round cells over here. These are your osteoblasts, and these will deposit your osteoid, okay? Osteoid is right here. Osteoblasts deposit your osteoid. And then you have osteoclasts, which is your bone resorption cells, which basically are the cells that break down your bone and are responsible for strengthening your bone, etc., etc. You guys probably took this in histology already, so I won't go into too much depth. Um, let's just one second. Okay, let's just talk about the difference between endochondral and intramembranous ossification again. I want you guys to keep this in mind because it can be a simple, quick question that they can ask, and you guys should be able to answer it without any issue. Okay, so endochondral ossification, you have a cartilage template, and the bone will replace this cartilage. Intramembranous ossification, you have no cartilage template, and the bone will directly form from the mesenchyme. Okay, that's it. That's all that there is to your ossification. Okay, so now let's talk about the skin real quick. So what you need to know about the skin is that the skin has three layers. It has the epidermis, the dermis, and the hypodermis. Epidermis is your outermost layer. It is avascular. It is made up of your keratinocytes. Then you have the dermis, which is your connective tissue layer. As you can see over here, it has your blood vessels. It has your glands and follicles. We'll be talking about this in a little. Then we have our hypodermis, which is our deepest layer of our skin, and it basically is made mostly up of fat, and it's basically made mostly up of fat. So this is our histological section over here. We can see our epidermis is up here. Then we have the dermis and the hypodermis most deep. In the dermis, you can see your other sebaceous glands and the glands that we were talking about in a little bit. Hypodermis, you have mostly fat. Epidermis is avascular, does not have any blood vessels, and it's made up of mostly keratinocytes. Now let's talk about epidermis specifically. So epidermis, uh, you have four layers in your epidermis when it's thin skin. Okay, so skin all over your body, other than the skin in your palms and your feet, is known as your thin skin. So your your epidermis, which is your thin skin, is made up of four layers. It has your stratum basal, which is your deepest layer. It is a single row of cells. It has the stem cells, melanocytes, and Merkel cells. Okay. Then you have your stratum spinosum. It is the layer right above your stratum basal. It is made up of. It has a spiny appearance because of your desmosomes, and it also has Langerhans cells over here. Okay. Then you have your stratum granulosum. This is your flattened layer of cells. As you can see over top over here, three is your stratum granulosum. It is deeply basophilic, so it's much more darkly stained compared to your other layers, and it is basically a thin line. That is seen over here. Then you have your stratum corneum, which is your uppermost layer of skin. It is made up of dead keratinized cells, which are known as your corneocytes, and this layer is continuously being shed and being replaced. Okay, over here you can see the arrow is pointing towards your desmosomes. Okay, between your desmosomes. Okay, this is basically your stratum spinosum, as you know, because stratum spinosum has is your spiny cell or your prickle cell layer. So that means it has the spiny appearance due to your desmosomes. Over here, you can see your capillary. It is in your dermis. Okay. Um, Now this is all for your epidermis and your thin skin. An easy way to remember the layers is baby spiders go crazy. I put this mnemonic if you guys want to use it to record to remember. Next up, your epidermis and your thin skin. So the epidermis in your palms and the sole of your feet. Okay, so again, you have all of the layers are the same. So you have stratum basal, which is your inner lowermost layer. Then you have your stratum spinosum. Then you have your stratum granulosum. And then after your stratum granulosum is the extra layer that we have, which is our stratum lucidum. Okay, stratum lucidum is it's an extra layer that is only found in your thick skin. Basically, you need this extra layer to help with friction because there's a lot of friction in your when you use your palms and your feet because you're walking, you're holding things. So there's a lot of friction, and your stratum lucidum is needed over there to help with this friction. And then you have the same layer as before, your stratum corneum. Again, you can see you can't see the capillaries over here in this section, but yeah. Uh, so now I have all of the layers and features of these layers, but for you guys did not really take them in depth in your histo lab, so I'll just leave these slides here. You guys can go and read them in your own time. Okay. Let's really quick talk about our melanocytes and your Langerhans cells. So over here, as we said earlier, our stratum basal, it basically contains our melanocytes and our Merkel cells. Okay. Um, the arrow over here basically is talking about the how the melanin is above your nucleus to protect the nucleus from UV rays and protect the damage, protect your nucleus from getting damaged and the DNA from getting damaged. Then you have our Langerhans cells, as we said earlier. These are found in our stratum spinosum. You can see that they're more white, so that's how you can remember them. And that's all. So your black arrows, your supranuclear melanin of keratinocytes of all layers in the epidermis. Okay. That's all you need to know for this section. Just remember what the Langerhans cells look like, and just know that in the keratinocytes they have a supranuclear melanin that's there to protect your nucleus and DNA from damage by UV rays. Okay. Thick versus thin skin. Again, as I said earlier, the only difference is that your thick skin also has your stratum lucidum, which is necessary to help with protection against friction. Let's move on to our pilosebaceous gland. So our pilosebaceous unit is made up of four things, okay? Before we move on to those four things, let's quickly mention. Quickly mention everything mentioned on the slide. So we have our sebaceous glands, we have our rectal pili muscle, we have our hair follicle right here, hair follicle again over here, and yeah, so we have our sweat glands over here, sebaceous gland, hair follicle as over here, as you saw over there, and that's all. That's all for now. Now, pilosebaceous unit. So our pilosebaceous unit is made up of four things. You have the one second. You have the four things. You have your hair follicle, you have your hair shaft, you have your sebaceous gland, and you have your erector pili muscle. So our hair follicle, along with the hair shaft, mixed with the erector pili muscle and the sebaceous gland makes up our pilosebaceous unit. Okay, so hair follicle is a structure that will produce the hair shaft. Our sebaceous gland is basically the gland that produces the sebum, which is necessary for lubricating your hair and your skin. And you have your erector pili muscle, which is basically a smooth muscle that will contract to cause your hair to stand on the end. For example, when you get scared or like when you're cold and you feel your hair rising, that's basically the function of the erector pili muscle. Okay. Another picture over here, you have your hair follicle right here with the hair shaft, sebaceous gland, erector pili muscle, acidosis of your sebaceous gland. We'll be talking more about our sweat glands later on. Over here is your hair shaft again with your medulla in the middle, then the cortex, and then you have the hair cuticle, and then the hair follicle all around it. Okay, so our hair follicle. So our hair follicle, complex structure. We have our hair matrix. Okay, where is the hair matrix? Okay, this is our hair matrix. Okay, the centermost is your hair matrix. Right at the base, you have your dermal papilla, which is basically the blood supply, which has the blood supply made up of loose, vascularized connective tissue. Basically allows for control of your hair growth. Then you have your hair matrix, which basically is your matrix keratinocytes and your melanocytes, responsible for giving your hair the pigment and its color. Then you have the internal root sheath, which is basically surrounds the growing hair shaft inside the follicle. Then you have, because you have an internal root sheath, you also have an external root sheath, which is basically the outer layer, which is continuous with your epidermis. And then you have your dermal papilla, which is basically the connective tissue that surrounds the whole thing, the hair shaft with the follicle. Okay, that's all you need to know about your hair follicle. Over here, this is your pigmented nail. Just remember that just memorize the picture. You have your nail roots. From the nail root, you have your nail plate. The nail plate has to rest on something, so that's your nail bed. And on the other side, you have your hyponychium right underneath, where your nail bed stops, and it's your nail plate overlying this hyponychium. Okay. Next, let's talk about our plantar skin, the Pacinian corpuscle. Pacinian corpuscle is basically a sensory receptor. It is found, plantar skin. It's found in the it's basically found in the sole of your foot. Okay. Um, it's found in the sole of your foot, yeah. Its function is basically it's a deep pressure receptor for mechanical and vibratory pressure, okay? Let's talk about the parts of our Pacinian corpuscle. So we have in the center you have our nerve, okay, and this nerve is then surrounded by an inner core and an outer core. The inner core is made up of flattened Schwann cells, and the outer core is made up of everything else. So it's made up of the collagen lamina, the fibroblasts, and the lymph-like fluid. Okay, an easy way to remember that you're looking at a Pacinian corpuscle is when you see an onion-shaped structure. Just know that's your Pacinian corpuscle. Everything that I just said. Another picture. So we have our sensory nerve in the center, which is our central axon, surrounded by our flattened Schwann cells, and then we have our collagen lamellae, fibroblasts, and lymphatic fluid surrounding the outer, basically, which is the outer core. Okay. Next up, let's talk about our sweat glands. So there are three main sweat glands in the skin. We have our eccrine, we have our apocrine, and we have our sebaceous glands. Let's go through each of them. So this is a big section showing our sebaceous gland and our eccrine sweat glands. Let's talk about each of them in depth. So our eccrine sweat glands is our these sweat glands are found all over our body, and their main function is to regulate our temperature through evaporative cooling. So they produce sweat, and the sweat evaporates from the surface of the skin, taking a little bit of the heat from our skin, and works to cool us down. Okay, the epithelium here is our stratified cuboidal epithelium. The structure of the gland is a coiled, simple tubular gland. Okay. So it's a coiled tubular gland, and it's made of stratified cuboidal epithelium. It has a very narrow lumen, and it's found on their dermis layer. Okay, so it's not found in the epidermis; it's found in the dermis. And they also have myoepithelial cells, which are basically muscular cells. You can think of them as they're responsible for contracting and allowing for the excretion of the sweat. Okay. You also have the duct that goes up and opens into the skin, known as our acrosyringium, which comes from our eccrine sweat glands. Okay. Another picture of our eccrine sweat glands. So you have our dark cell in the middle. Then you have our dark cell, light cell over here. You can see the light cell, and you have the myoepithelial cell surrounding the whole thing, responsible for contraction. Okay. Another picture of our eccrine sweat gland. Everything that I said: stratified cuboidal epithelium, simple coiled, tubular, narrow lumen, found in the dermis, have flattened myoepithelial cells on its surface. Okay. Next up, our sebaceous glands. So our sebaceous glands are associated with our hair follicles. We said they're part of the pilosebaceous unit. They're responsible for secreting sebum, which is basically the oily substance that lubricates your hair and your skin. These cells will look pale and foamy on your H&E stain because of the lipid that they contain. This lipid will be washed out when you prepare the slide, so they look very white. That's basically why they look pale and foamy. This gland is basically, again, same as your eccrine sweat gland. They're stratified cuboidal epithelium. They have, again, a simple coiled tubular structure. They have a very narrow lumen, again. And make sure to remember that these glands, they do not have myoepithelial cells, okay? So the eccrine sweat gland has myoepithelial cells, but these sebaceous glands do not have myoepithelial cells. Another image of the sebaceous gland. You have the acini of the sebaceous gland, sebocytes, and the basal cells around them. Okay, next up are apocrine sweat glands. So these sweat glands are the special sweat glands. They're not there for temperature regulation, but they're more related to our pheromones. So like scents, you could think of it as. And these sweat glands are not active, and they only become active once you hit puberty. Okay, so this sweat gland is different from the other two sweat glands in that it is again. Um, Not stratified cuboidal epithelium. It is simple cuboidal epithelium. Okay, so the other two sweat glands were stratified cuboidal epithelium, but this sweat gland specifically is our this sweat gland is our stratified cuboidal epithelium. This sweat gland, as you guys can see, has a very large lumen, and you can see it has a simple cuboidal epithelium. The tubular nature of this gland is again simple coiled tubular, and this sweat gland is found in our dermis, and it also consists of flattened myoepithelial cells, which are again responsible for contraction and for the excretion of sweat and the contents of the sweat gland. And this sweat gland is found in the axilla and around the anus, so around the perianal region. Okay, and that's all for the histology part of the crash course. All right, so lower limb, we'll be starting off with our hip bone. Okay, so our hip bone is one of the largest bones in our body. It's also known as our coxal bone. Okay, so the hip bone is basically made up of three main structures. You have your ilium, your ischium, and your pubis. Okay. I'll be talking about each of these in more depth later on. Let's, for now, first talk about the hip joint itself. Okay. The hip joint is a ball and socket joint. The ball is basically part of your femur, and it connects to the acetabulum, which is a cup-like structure of your hip bone. Um, this acetabulum is deepened by the acetabular labrum, which is basically a fibrocartilage ring that deepens the acetabulum to allow for more stability of the hip joint. Because the hip joint is a ball and socket joint, it has the greatest range of motion. Okay, so it has both flexion and extension. It has abduction, which is moving away from the body, and adduction, so adding the limbs together, so moving towards the body. It also has external and internal rotation. Okay, all of these are parts of the hip joint's movements. So in addition to this, the hip joint also allows for circumduction. Circumduction is basically a combination of all the six movements that I just mentioned, and this allows for circumduction. Now let's talk about the parts of the hip bone itself real quick. So the hip bone is made up of a couple of things. So you have your ilium, this is your ilium. Then you have your sacrum, okay, this is your sacrum. You have your pubic bone right here. You have your ischium right here. And from behind, you can see your coccyx right here, okay? These are the bony parts of your hip bone. So the hip bone is made up of the ilium, the pubis, and the ischium. Okay, all three of these bones connect and join at the acetabulum. Acetabulum is a cup-shaped structure that is formed by the joining of the ilium, the pubis, and the ischium. Okay, over here you will find the triradiate cartilage. Okay, this triradiate cartilage is a Y-shaped cartilage that is found in children, but at puberty it will fuse and will disappear. Okay, everything that I just said in words right here. So as we know, our hip bone is our ball and socket joint. You have the head of the femur, which will articulate with the acetabulum of the hip bone. The acetabular labrum is responsible for deepening the cavity of the socket, allowing for more stability of the joint. And over here is a picture from your dry lab. So you have your ilium right here. You have your posterior superior iliac spine at the back. At the front, you have your anterior superior iliac spine. Right underneath the anterior superior iliac spine, you have your anterior inferior iliac spine. And right underneath your posterior superior iliac spine, you have your posterior. Right beneath your posterior inferior iliac spine, you have your posterior inferior. Okay. Right beneath your posterior superior iliac spine, because you're the superior, you're going to have an inferior. You have your posterior inferior iliac spine. Over here, you have your ischial spine and the obturator foramen. Okay, this is the other picture. So over here, you can see the acetabulum formed by your ilium. You have your ischium right here and your pubis right here. So you have your pubic tubercle right here. Above the pubic tubercle, you have your superior pubic ramus. Beneath the pubic tubercle, you have your inferior pubic ramus. Between the pubis and the ischium, you have your ischiopubic rami, and behind the and in front of the ischiopubic rami, you have your ischial ramus and the ischial tuberosity. Behind, by the way, the ischium is behind. Let's talk about the ligaments of the hip bone now. So, starting off with your iliolumbar ligament. So, your iliolumbar ligament is a very strong ligament. It comes from your L5 transverse process and connects to the ilium. So, this is your ilium, comes from the L5 and connects to the ilium. Next up, we have your anterior um, sacroiliac ligament. Okay, the anterior sacroiliac ligament is a very thin ligament. Okay, it's there to reinforce the connection between the sacrum and the iliac, and connects the sacrum and the ilium in the name itself. Okay, because there's an anterior one, you'll have a posterior sacral iliac ligament. Okay, the posterior sacral iliac ligament is much stronger than the anterior sacroiliac ligament. It basically again stabilizes the sacroiliac joint posteriorly by connecting the sacrum and the ilium. Okay, now we have the pubic symphysis. Okay, the pubic symphysis is basically a secondary cartilaginous joint. It basically is there to connect the two pubic bones. Okay, and it's basically a fibrocartilaginous disc. Okay, next up we have our obturator membrane. So this hole over here, if you guys saw previously, this hole over here is our obturator foramen. Okay, now this obturator foramen is covered by a membrane, and this membrane is our obturator membrane. Okay, it basically also has it has a small opening that allows for the obturator canal to allow the neurovascular bundle to pass through, etc., etc. Then we have our sacrotuberous ligament. Okay, the sacrotuberous ligament is a very large ligament. It goes from the sacrum to the ischial tuberosity. Okay, to the ischial tuberosity, and it stabilizes the pelvis and basically converts the notches in your sacrum into foramina. Okay. Next up, we have our sacrospinous ligament. The sacrospinous ligament is a triangular ligament. You can kind of see it's like kind of triangular. It basically connects the sacrum to the spine. And it helps form the sciatic foramina and prevents the rotation of the sacrum itself. Okay, so that's it for the hip bone. Okay, let's move on to the hip muscles. So our hip muscles are basically they can be grouped by their primary actions. So they can be grouped by our primary actions. Okay. So basically, what you want to focus on over here is the origin, insertion, action, and the innervation of each of the hip muscles. So starting off with over here is an overview of all the hip muscles that we'll be discussing right now. Let's start off with the largest hip muscle and the largest muscle in our body. The largest hip muscle, which is our gluteus maximus. Okay. Um, the gluteus maximus is the largest and it's the most superficial gluteal muscle. Okay. It's one of the largest muscles in our body, and its main action is hip extension. So this would include rising from sitting, climbing stairs, or running uphill. All of these are functions of the gluteus maximus. The gluteus maximus is also responsible for the lateral rotation. Okay, so rotation outwards, lateral rotation of the thigh, and it's also responsible for the stabilization of the knee joint laterally through the iliotibial tract. Okay, iliotibial tract. Through the iliotibial tract. Okay, so basically it stabilizes the knee joint laterally, and it tensors the fascia lata through a iliotibial tract. I'll be discussing more. I'll be talking more about this specifically later on. And make sure to remember that the gluteus maximus is innervated by your inferior gluteal nerve. Okay, so you have gluteus maximus. Let's move on to our this is before that. This is a picture from the wet lab for your gluteus maximus. As you can see, this is the largest muscle, and you can't really see any other muscle. But basically, next up, once we flip the gluteus maximus, we'll be able to see all the other gluteal and hip muscles. Okay. So next up, we have our gluteus medius. Okay, the gluteus medius is our middle gluteal muscle. It originates from the outer surface of the ilium. Okay, over here. It originates from the outer surface of our ilium, and basically it inserts into the greater trochanter of the femur. Its action is to abduct, so move away from the body, and medially rotate the thigh. Okay, so the gluteus maximus laterally rotates, and the gluteus minimus medially rotates the thigh. Okay, the innervation for the gluteus medius is different as well. So it's innervated by the superior gluteal nerve. So the maximus is innervated by the inferior gluteal nerve, and the medius is innervated by the superior gluteal nerve. Okay, uh, this um, this muscle is especially important for one clinical scenario that I'll be talking about later. Basically, it helps keep the pelvis level with your body when one of your foot is off the ground when you're walking, for example. Okay, so over here you can see your gluteus medius. So you have flipped over the gluteus maximus, and right under it is your gluteus medius. Again, over here, this is your gluteus medius. The gluteus maximus has been removed from this section. Uh, just keep the pictures in mind. You should be able to identify by now pretty easily. Um, but yeah, it'll get easier as we go along. Next up, we have our gluteus minimus. Okay, gluteus minimus is the smallest of the three gluteal muscles. It originates again from the outer surface of the Wait, let me show you guys. It's right here. Again, it originates from the outer surface of the ilium, okay? It inserts into the lateral surface of the greater trochanter. And again, same action as the gluteus medius is where it abducts and medially rotates the thigh. And again, it has the same innervation as the gluteus medius, which is the superior gluteal nerve. Now, over here, you can see this very small muscle right here is your gluteus medius, okay? Now you've removed both the gluteus maximus and the gluteus medius, and right underneath both of them is your gluteus minimus. Next up, let's talk about the Trundleberg sign, which is basically a clinical test that you guys do, basically to test for the um, function of the gluteal nerve damage. So, normally when you stand on one leg, the gluteus medius and minimus will contract and they cause the pelvis to become level. Okay, so when you're standing on one leg, your pelvis is on the same side. However, when there is superior gluteal nerve damage, these gluteus medius and minimus muscles will become weak and they will no longer be able to hold the pelvis up. Okay, so what will happen is that the pelvis will drop on the opposite side of the damaged nerve. Okay, so if you have damage over here to the right superior gluteal nerve, the right gluteus medius and minimus will no longer function, and the left side of the hip will drop down, because basically what this has to do is it's like this, right? So these two muscles will contract. Once they contract, they move the hip back into place. Okay, but when the innervation is lost, the hip will droop to the opposite side. Hope this makes sense. That's all for the Trundleberg sign. This could be a question that they ask, but I don't think it's very likely to come in the OSPE. But if it does come, now you guys know. Next up, we have our tensor fascia lata, okay? The tensor fascia lata inserts into the iliotibial tract, okay? Which is a thick band of fascia that runs down on the lateral aspect of your thigh, and it goes to the lateral tibia, okay? It basically is responsible for stabilizing the knee joint laterally, and it tenses the tensor fascia lata via the iliotibial tract, and again, stabilizing the knee joint, okay? Um, that's all you need to know for this. I remember last year we had an OSPE question of this. So make sure you can differentiate between the tensor fascia lata, the muscle, and the tract, because last year, I think, if I'm not mistaken, they bought us the same question. They bought us a wet lab cadaver where the pin was placed on the iliotibial tract. However, it was very close to the tensor fascia lata, so a lot of people got that wrong, where they mistakenly labeled it as tensor fascia lata instead of the iliotibial tract. So make sure to keep this in mind. Over here, cadaver image of the tensor fascia lata. So over here, you can see that this thing is your muscle, and over here is your band of fascia that runs down the lateral thigh to connect to the lateral tibia. Okay, tensor fascia lata. Next up, we'll be talking about the other muscles of the gluteal region, starting off with the piriformis, okay? The piriformis is basically responsible for the lateral rotation of the hip and abduction of the flexed hip, okay? So you want to remember, it abducts the flexed hip, not the normal hip. So its origin is from the sacrum and it exits to the greater sciatic foramina, and then it inserts into the superior aspect of the greater trochanter of the femur. And its function, again, as I said earlier, was to laterally rotate the extended hip and extend and abduct the flexed hip. So it does two things. Okay, once the hip is extended, it will laterally rotate it. Okay, and once the hip is flexed, it can abduct, so move away from the body. That is what the piriformis does. Okay. It's innervated by the S1 and S2 nerve roots. Over here, you can see your piriformis muscle right here. This is your piriformis muscle. Once you have removed the, if I'm not mistaken, this is your medial gluteus medius over here, and right under it, you can see your piriformis muscle. So this is now let's talk about a clinical syndrome, which is our piriformis syndrome. Okay, this piriformis syndrome is usually seen in cyclists. Okay, why is it seen in cyclists? Is because uh, piriformis muscle becomes hypertrophied and becomes very large in cyclists because they use this muscle a lot during cycling. Okay, so what this muscle does is that you have the sciatic nerve that runs right underneath the piriformis muscle. Once this muscle is enlarged, it will cause a decompression of the sciatic nerve, and this causes pain that is called sciatica. Okay, sciatica is a characteristic pain, which basically is pain that radiates down from your buttock to the back of your leg, and this is usually again seen in cyclists once the piriformis muscle is enlarged and compresses the sciatic nerve. Okay, make sure to keep this in mind. They could easily bring a case where they're like, oh, which of they have a pin on a couple of muscles, and they're like, oh, which of the following muscles is enlarged when a person has been cycling for an extended period of time or for many years. Okay. Or they could also ask you about the nerve, which nerve is compressed in piriformis syndrome, and then you guys should know that it's the sciatic nerve. Okay. Next up, the obturator internus muscle. Okay, the obturator internus muscle is a lateral rotator of the hip. Its origin is basically in the internal surface of the obturator foramen. We talked about the obturator foramen and the obturative membrane. So its origin is from the obturator foramen and membrane. The muscle basically what it does is that it passes out of the pelvis to the lesser sciatic foramen, and its function again is to laterally rotate the extended hip and abduct the flexed hip. Okay, so again, the function of the piriformis and the obturator internus is the same thing. They both laterally rotate the extended hip, and they abduct the flexed hip. Okay, make sure to remember they both have the same function. Next up, let's talk about the superior and inferior gemellus muscles. Okay, so these muscles are basically over here. You can see this is your superior gemellus muscle, and over here, as you can see, is the superior gemellus muscle, and between the superior and inferior gemellus muscle, you have your obturator internus. So you have the superior gemellus and your inferior gemellus, and between the two, you have your obturator internus. Okay, so both these muscles will insert on the medial surface of the greater trochanter of the femur. The superior gemellus will attach above the obturator internus tendon, and the inferior gemellus will attach below the obturator internus muscle and above the obturator externus. Okay, let's move on to the quadratus femoris. Okay, the quadratus femoris is a small square-shaped muscle. You could see it in the previous diagram over here as well. A small square-shaped muscle. What this muscle is basically responsible for is lateral rotation and the stabilization of the hip. So it only laterally rotates the hip and stabilizes it. Its origin, again, is from the lateral border of the ischial tuberosity. And over here, it inserts into the intertrochanteric crest. Okay, we'll be talking about the bony landmarks of the femur later on. But keep in mind, for now, is that the quadratus femoris will insert into the intertrochanteric crest, and it originates from the ischial tuberosity, which is a small prominence on your ischium, which we talked about earlier. Let's quickly go over the blood supply of the hip muscles. So the superior gluteal artery, branch of the internal iliac artery. So we have our main artery, which is our internal iliac artery. This will branch into the superior and inferior gluteal arteries. Okay, the superior gluteal artery will go and supply your gluteus medius and minimus, and your inferior gluteal artery will go and supply your gluteus maximus. Okay, the superior gluteal artery will exit above the piriformis via the greater sciatic notch, while the inferior gluteal artery, because it's inferior, it will exit below the piriformis via the sciatic notch. Okay. Next up, you have the profunda femoris. Okay, I'll talk more about this artery a little later on again. But for now, the profunda femoris is a branch of the femoral artery. It gives off the medial and lateral circumflex arteries, which are responsible for wrapping around your femoral head, and they're the main blood supply to your femoral head. As you guys probably took in your lectures already. If that there is if there's a femoral neck fracture, it's very common to have avascular necrosis, etc., because these arteries get damaged. Next up, the nerve supply for the hip muscles, okay? So we have our inferior gluteal nerve and we have our superior gluteal nerve. Inferior gluteal nerve is responsible for this, comes from the roots of L5, S1, S2, and it supplies the gluteus maximus. And this is the only muscle that the inferior gluteal nerve supplies, okay? Superior gluteal nerve, on the other hand, comes from the L4, L5, S1, okay? Because think of it as, it makes sense, right? Because if superior, it's more further up, so its roots are also further up. So it has L4, L5, and S1, and inferior gluteal nerve has L5, S1, and S2, okay? So superior gluteal nerve will supply the gluteus medius and minimus, responsible for hip abduction and medial rotation. And uh, key fact that you should know, again, because it's superior, it exits above the piriformis. It also supplies the tensor fascia lata, and it travels with the superior gluteal vessels. Okay. So all of the nerve supplies for the hip muscles, real quick. Gluteus maximus, as we said, inferior gluteal nerve. Gluteus medius and minimus comes from the superior gluteal nerve. You have the tensor fascia lata, which is supplied by the same muscles, same nerve as the medius and minimus, which is the superior gluteal nerve. The piriformis comes from the S1, S2. The obturator internus comes from the nerve, the obturator internus, which comes from L5 and S1. And the quadratus femoris comes from the nerve to the quadratus femoris, which is L4, S1. Okay. With that, we are done with the hip portion of the anatomy. Now let's move on to the femur. Okay, so the femur is our largest and the strongest bone in our body, as we all know by now. So the head of the femur basically is the round shaped structure, the ball that goes and connects to the acetabulum of the hip. So it's responsible for forming the ball and socket joint, the hip joint. It contains the fovea capitis, which is a small pit or depression found on the medial surface of the femur. You can't really see it from this view, but I'll show it to you guys later. Over here, you'll have the ligamentum teres, which basically attaches to this fovea capitis, and it also carries the foveal artery. Then you also have the neck of the femur, which basically connects the head to the shaft. So this is the neck connecting the head to the shaft. This is the most common site of femoral fractures, and is especially prominent in elderly women with osteoporosis. Okay. Next up, the greater and lesser trochanters of the femur. Okay. So over here, you can see your greater trochanter. The greater trochanter is your large bony projection on the top of your hip bone. It's responsible for the connection to the gluteus medius and minimus. And then you have the lesser trochanter. Okay, the lesser trochanter is underneath over here. It's the posterior medial projection, and it's the attachment site for the iliopsoas muscle, which is your main hip flexor. Okay. Next up, we have the intertrochanteric lines. Okay, so there are two things. You have the intertrochanteric line and you have the intertrochanteric crest. Okay, the intertrochanteric line is found on the anterior surface of the femur, and the intertrochanteric crest is found on the posterior surface of the femur. Okay, the intertrochanteric line runs between the trochanters on the front of the femur and is the attachment site of the joint capsule and the iliofemoral ligament, and the iliotrochanteric crest connects the trochanter at the back of the femur, and it basically connects the quadrate tubercle and is the attachment site for the quadratus femoris. The muscles that one of the muscles that we just discussed, the square-shaped muscle, it's the attachment site. Its attachment site is the intertrochanteric crest. So again, line is anterior, crest is posterior. Make sure you know the differentiation. Another thing that if you guys noticed on the model itself is that if you ran your finger over the crest and the crest, you'd feel it to be a little more prominent. Okay, that's something else that you could keep in mind if in case you guys forget. But just keep in mind, crest is posterior, line is anterior. Now, let's talk about the ligaments of the hip joint. Okay, starting off with the iliofemoral ligament. Okay, the iliofemoral ligament is the ligament between the ilium and the femur. You can think of the ligaments of the hip joint itself. Of the hip joint itself as like they're just named based on the two things that they connect. So the iliofemoral connects the ilium and the femur. The ischiofemoral connects the ischium and the femur. The pubofemoral, pubis and the femoral. Okay, these are the three main ligaments that you guys want to know and be able to identify. I'll go through them again. So again, the iliofemoral is the strongest Y-shaped anterior ligament. It's found strongest Y-shaped anterior ligament. It's there to prevent a hyperextension. Then we have the ischiofemoral ligament right here, connecting the ischium and the femur. It's one of the weaker ligaments and it's found posteriorly and it prevents the medial rotation. So you can make sense because if the femur was to rotate medially, this ligament will be stretched and will prevent the excessive medial rotation of the hip. Next up, we have our pubofemoral ligament, which is found inferior. Okay, and this ligament is basically there to limit your abduction and extension of your hip. Okay, connecting between again the pubis and the femur. Next up, we have the ligament of the head of the femur. Okay, this is our intra-articular ligament, so it's inside the articular capsule. Carries the foveal artery and is very especially important in children. Okay, that's it for the ligaments. I'll go through these pictures that you guys had in Dr. Atif's slides. So again, sacrum, you can see this is your sacral bone. This is your iliac bone. Between the over here, you can see the greater trochanter. You have, since this is the anterior view, again, anterior view, so it's the line. So intertrochanteric line between the greater and lesser trochanters. Over here, you have the iliofemoral ligament between the ilium and the ilium and the between the ilium and the femur. Then over here, you have the pubofemoral ligament between the pubis and the femur, and the ischiofemoral. You can't really see. Okay, ischiofemoral ligament is right here. You can see it from posteriorly, because the pubis again is posteriorly located and connects to the femur. Okay, that's all you need to know for the ligaments. Again, another picture. As I said, ligament of the femoral head. Over here, you'll have this is the ligament of the femoral head. It will carry the foveal artery, which is responsible for supply to the head of the femur. And yeah, again, another picture from your dry lab. Over here, you can see this is connected to the pubis, so it's your pubofemoral ligament. Iliofemoral because it's connected to the ilium. Again, over here, you can see the pubis right here, so it's connected to a pubofemoral ligament, inferiorly located, remember that. And then you have the ischiofemoral ligament, posteriorly connecting between the ischium and the femur. Okay, more pictures again from your dry lab. As dry lab slides from Dr. Atif, iliofemoral, iliofemoral, both of these V-shaped, Y-shaped, whatever you want to call it. Pubofemoral inferiorly between the pubis and the femur, inferiorly located on the anterior aspect. Ischiofemoral is on the posterior aspect between the ischium and the femur. Okay. Next up, we'll be talking about the blood supply of the femur. This is not want to go. Okay. So now, the blood supply of the femur. So there are two main arteries that supply the femoral head and the femoral neck. You have the medial circumflex artery and the lateral circumflex artery. Medial circumflex artery is the main blood supply to the head and the neck, and it wraps posteriorly around the femoral neck, and it's especially at risk during femoral neck fractures. Lateral circumflex femoral arteries supply the anterior femoral neck and the greater trochanter. Okay. Then we also have artery to the head of the femur, which is through the foveal artery. As you mentioned earlier, we have as you mentioned earlier, we have the what's it called? Foveal artery. This artery arises from the obturator artery. It travels within the ligaments of the head of the femur to supply the femoral head. We mentioned this earlier. There's a small ligament that goes inside that is basically attached to the head of the femur, and inside this ligament you have your foveal artery. And again, the main blood supplies to the hip joint is the femoral artery, which gives rise to the profunda femoris artery. And you have the obturator artery, which gives rise to the foveal artery. Okay. Keep in mind that the foveal artery is especially important in children. You guys probably took this in your normal lectures. This is especially important in children, and adults, the other blood vessels will take over to supply the head of the femur. Okay. Let's talk about the femoral artery a little more. So the femoral artery is a continuation of your external iliac artery, okay? And this artery goes beneath the inguinal ligament to form the femoral artery. Okay, uh, the deep the deep femoral artery is also known as your profunda femoris. It's the largest branch of your femoral artery and is the primary supply to all of your thigh muscles. Okay, next up you have your medial circumflex artery that we just mentioned. It wraps posteriorly to supply the femoral neck and the head, and you have the lateral circumflex artery, which basically is responsible for supplying the anterior thigh muscles. Okay. Now, what happens when you have a femoral neck fracture? Okay, so over here you can see in clearly in the X-ray is that you have a femoral neck fracture. Okay, in the femoral neck fracture, the most common artery that is injured is your medial circumflex femoral artery. Okay, this artery is your main blood supply to your femoral head. If this artery will rupture, the blood supply will be lost, and this will lead to avascular necrosis. Okay, which basically means the bone will no longer have any blood supply, and what will happen is the bone will start to die, and this is called avascular necrosis. Okay. Um, these femoral neck fractures are particularly common, and they're usually seen in elderly women, so postmenopausal women. You guys will take this later on because estrogen is one of the hormones that really helps maintain the strength of the bone. Once the supply of estrogen drops in postmenopausal women, there'll be a high risk of osteoporosis, and once this osteoporosis happens, it gives an increased risk of bone fragility and femoral neck fracture. Okay. With that, we're done with the femur. Okay, now let's move on to the muscles of the thigh. All right, so again, thigh muscles. So our thigh muscles are basically divided into three compartments. So we have our anterior thigh compartment, medial thigh compartment, and posterior thigh compartment. Anterior compartment is responsible for knee extensors and supplied by the femoral nerve. Um, Medial compartment is for the hip adductors, so they add the legs together, and these are mostly supplied by the obturator nerve, with one exception. And then you have the posterior compartment, which basically has your hamstrings and it has your knee flexors, hip extensors, and these are supplied by the sciatic nerve. Okay, let's start off with the anterior compartment of the thigh. So, as you guys can see over here, these are the muscles of the anterior compartment of the thigh. We have our sartorius, we have our quadriceps femoris, we have our rectus femoris, we have our vastus lateralis over here. Once you remove the two muscles, you have the vastus intermedius, and then you have the vastus medialis. Okay, let's talk about each of these muscles by themselves. So, the primary function of the anterior compartment is to flex the knee. Okay, all of these muscles are innervated by the femoral nerve and branch of femoral nerve roots L2, L3, L4, and the four quadriceps muscles. Basically, all converge together to form the quadriceps tendon. Okay, this quadriceps tendon will go and attach to the patellar tendon, and which then will go and attach to the tibial tuberosity. You guys, I'll talk about this later. So, let's take each of these muscles. So we have the rectus femoris, okay? The origin of the rectus femoris is the anterior inferior iliac spine. It's responsible for flexion of the hip, and it's the only quadriceps muscle that will cross the hip joint, okay? Next up, we have our vastus lateralis. This muscle will originate from the greater trochanter and the lateral lip of the linea asperna. I hope I pronounced that right. I don't know. And it's responsible again for the knee extension, and basically inserts into the tibial tuberosity. Uh, I don't think you need to know the insertions, but for completion's sake, I'll mention they're here if you guys want to read it in your own time. Then you have the vastus medialis, which is basically originates from the medial lip of the linea asperna, and this muscle is responsible for again knee extension, as all the other thigh muscles. Then we have our sartorius. Okay, now this muscle's origin, again same as rectus femoris, is the anterior superior iliac spine, and it goes to the pes internus and goes and inserts into the pes internus. You don't need to know that again. And it's responsible for hip flexion and also hip abduction. Also has a little bit of hip abduction motion. And that's all you need to know regarding the anterior compartment. Let's look at some more pictures to better visualize the anterior compartment. So again, um, we have our rectus femoris muscle over here, right here. Then we have our sartorius muscle right here. This is the sartorius muscle. You can see it's crossing over here. Over here is the tensor fascia lata is the muscle, and then it goes inserts to the um, uh, to the side of the knee and helps stabilizes it. We mentioned that earlier. And then we have the vastus lateralis muscle, vastus medialis muscle. If you were to remove the rectus femoris, you could see the vastus intermedius muscle. Okay, that's it for the anterior compartment of the thigh muscles. Now let's move on to the medial compartment. So the medial compartment has four main muscles that we'll be discussing. We have our more than four actually, not four main muscles. We have more than four. I'll be talking about all of them. So over here you can see our obturator externus, abductor brevis, adductor magnus. We also have adductor longus. Um, Over here again, we can see you have our obturator externus, we have our pectineus, we have our adductor brevis, adductor longus, adductor magnus. We also have our gracilis. We also have our adductor magnus. All of these are the external medial compartment of the thigh. Okay, let's talk about them in a little more depth. We have this is our medial compartment of the thigh. The medial compartment of the thigh is usually its main function is hip adduction, so bringing the hip muscles together. Think about it. So if this is your femur and this is the midpoint of your body, and all of these muscles are connected to the midpoint of your body, what's the function? It's to bring it closer towards your midpoint, right? So the medial compartment is responsible for adding basically hip adduction, which is adding your limbs together, bringing them towards their midline. Okay. All of these muscles are innervated by the obturator nerve, L2 to L4, other than the tibial part of the adductor magnus, which is innervated by the tibial division of the sciatic nerve. Okay, this is the only exception in the medial compartment that you want to remember. Everything is innervated by the obturator nerve except for the tibial parts of the adductor magnus, which is innervated by the tibial division of the sciatic nerve. Okay, so adductor longus, it originates from the body of the pubis, uh, uh, joins into the middle one third of the linea asperna, aspera, and its function again is hip adduction. Then you have the adductor brevis, body and inferior of ramus is where it comes from. Linea aspera is again where it goes and inserts into. Its function again is to cause hip adduction. Then you have the adductor magnus, which comes from the ischiopubic rami and the ramus and the ischiotuberosity. Again, goes and inserts into the linea aspera and the adductor tubercle, and its main function again is adduction. But in addition to adduction, is also part of it also has a role in extension. Okay, then we have the gracilis, which basically originates from your inferior rami of the pubis, inserts into the ascernus. You guys don't need to know the internus because I'm just reading them for completion's sake. It goes and inserts into the trochanteric for of no. Okay. So the gracilis goes and inserts into the pes ascernus, and so its function is hip adduction, but it also has a function in knee flexion. Okay. Then you have the obturator and externus. Its margins are the obturator foramen. It comes from the margin of the obturator foramen, inserts into the trochanteric fossa, and its action is hip external rotation. Then you have your pectineus muscle, which comes from the pectineal line of the pubis, inserts into the pectineal line of the femur, and its function is again hip adduction and flexion. Okay. More pictures. So medially, the most medial, you have your gracilis. Over here, you can just barely make out the adductor magnus, and over here is your adductor longus. So again, most medially is your gracilis. Adductor longus is right here underneath the pectineus. Above the adductor longus is your pectineus. Then you have the adductor brevis. Then you also have the obturator externus, which again, we said it comes from the obturator foramen, which was the hole that we talked about earlier on. And it goes and inserts into the trochanteric fossa behind the femur. Then over here, you have the adductor magnus, which is low-key the biggest one over here. You can kind of make it out. Make sure again to remember about the adductor magnus is the main point about the adductor magnus that you want to remember and is easily testable is that it's not purely supplied by the obturator nerve. It's also supplied by the tibial portion of the sciatic nerve. Okay, make sure to remember that. Now, we talked about the medial compartment, but the medial compartment is made of the adductors, and so they basically make a structure in your body known as your adductor hiatus. Okay, the adductor hiatus is basically a gap through which it's a gap in your. Let me show it to you. right here. This is your adductor hiatus. We saw it in the previous slide over here, right here. This is your adductor hiatus. What's adductor hiatus is basically is it is a gap in your adductor magnus muscle, okay? And through this gap, you have the femoral artery and vein pass through from the medial and anterior thigh into the popliteal fossa, where they'll become the popliteal vein and artery, okay? That's the main thing that you want to remember about the adductor hiatus. It's an opening allowing for the passage of the femoral nerve, which will then go, femoral artery and vein, from which they can go to the popliteal fossa, where they become the popliteal artery and vein. All that you need to know about the adductor hiatus. Okay. You also need to know the boundaries of the adductor hiatus. Okay. So over here, you can make out the adductor canal. Okay. So adductor canal, anteriorly and laterally, you have the vastus, vastus medialis. Okay. The medially, you have the sartorius. Okay. This is your sartorius. Then posteriorly, you have two muscles. It's only one muscle, but it's like for completion's sake, the slide said two muscles, so we'll say two muscles. It has the adductor longus and magnus, and the contents again are the femoral artery and vein, saphenous nerve, and the nerve to the vastus medialis. These are the contents of the adductor hiatus. Next up, since we're talking about gaps and places in the muscles, let's talk about the femoral triangle. Okay, so what the femoral triangle is basically is a region on your anterior superior thigh. Okay, anterior superior thigh, you have a triangle, and this triangle is your femoral triangle. So the base of the femoral triangle is made by the inguinal ligament. Okay, inguinal ligament makes the base of the femoral triangle. Laterally is the medial border of the sartorius. So laterally, you have the sartorius, the muscle that crosses. So this is the sartorius. It makes the lateral border of the femoral triangle. Medially, you have the medial border of the adductor longus muscle. Okay, so these are the three borders that you need to remember for the femoral triangle. Superiorly is your inguinal ligament. Laterally you had your sartorius, and medially you had your adductor longus, and this all of these will make your femoral triangle. Okay. You also want to remember the floor and the roof, floor of the femoral triangle. The floor is formed by the laterally is formed by the iliopsoas muscle, and medially is formed by the pectineus muscle. So let's talk about the contents of the femoral triangle. The mnemonic that you guys probably already have memorized by now is navel, where N stands for the femoral nerve, A for the artery, V for the vein, E for the empty canal, which is your femoral canal, and L for the lymph nodes. Okay. So again, so a nerve, artery, vein, femoral canal, and the lymph node. This is the contents of your femoral triangle. Again, laterally you have your sartorius, and medially you have no medially is laterally you have your medial border of sartorius, and medially you have your adductor longus. Superiorly you have your inguinal ligament. Okay, that's for the femoral triangle. Again, another image from Dr. Atif's slides. You have your inguinal ligament right here. You have your sartorius. You have your adductor longus right here. Inside the contents, again, use navel as your mnemonic, femoral nerve, artery, vein, empty space, and then you have your you have your deep inguinal lymph nodes. Okay. Picture on a cadaver. So again, you can see your inguinal ligament right here, sartorius muscle laterally, adductor longus muscle medially, contents over here, lateral to medial navel. Behind over here, you can see the pectineus muscle. And over here, as you guys just saw, was your adductus longus muscle. Okay. With that, we're done with the medial compartment of the thigh. Next up, we have our posterior compartment of the thigh. Okay. So posterior compartment of the thigh is basically responsible for your knee flexion and hip extension. Okay, so these are the muscles. You have the semitendinosus, you have the semimembranosus, you have the biceps femoris, and you have with two heads, the long and short head. So let's talk about each of them. So again, the posterior compartment is made up of your hamstring muscles. Okay, these muscles are responsible for your knee flexion and your hip extension. Okay, all of these muscles are innervated by the sciatic nerve, which is also your largest nerve in the body. Okay, we talked about how the sciatic nerve passes underneath the piriformis. The same nerve is responsible for the supply of the nervous supply for the posterior compartment of your thigh. So we can remember the muscles of the thigh by two semis and one biceps. Okay, think of it as two semis and one biceps. So you have two semi muscles. So you have the semitendinosus and the semimembranous, and then you have the biceps. The biceps is technically one muscle, but so you have the long head and short head, which you guys want to keep in mind. So let's talk about each of them. So your biceps femoris, the long head comes from the ischial tuberosity, inserts into the fibula, and its action is your knee flexion and hip extension. Okay. Um, then we have our biceps femoris, which origin is the femur. It inserts into the fibula, and its action is knee flexion only. Semitendinosus comes from your ischial tuberosity. It inserts into the pes. I don't know how to pronounce that. Whatever. And its action is to again flex the knee and extend the hip. Okay. Semimembranosus, on the other hand, attaches to the posterior aspect of the medial condyle of the tibia. It inserts into the posterior medial condyle of the tibia, and its action is knee flexion and hip extension. Okay, so again, talking about the innervation, all of the muscles are supplied by the sciatic nerve. So you have two divisions of the sciatic nerve. You have the tibial division and the common fibular division. The tibial division is responsible for all of the muscles except for the short head of the biceps. Okay. The common fibular is the one that's responsible for the nerve supply of the short head of the biceps femoris. Again, more pictures over here. So you can see the medial division of the biceps femoris. This is your biceps femoris muscle right here. So you have the semitendinosus, and then you have the biceps with the short and long head. Long head is more medially located, short head is more laterally located. Short head is more laterally located. Okay. Then again over here is the biceps femoris, the short head over here. You can see over here. Long head and short head is the over here would be the biceps femoris. Underneath it is you have the short head of the biceps femoris. This large muscle over here is your semimembranosus. It's like a membrane. Semitendinosus is mostly tendon. This is a distinction that you guys probably already made on your cadavers. You can see where the semitendinosus has a very large tendon, and this is a key identification factor for the semitendinosus. This immediately to it, you have your semimembranosus, then you have the biceps femoris, and then between nerve supply for all of these muscles, your sciatic nerve. As we said, we have two branches. We have the tibial and the fibular branch. Okay. Let's talk about the blood supply of our thigh muscles real quick. So we have, again, our femoral artery, which is a branch of our external iliac artery. It's responsible for the supply of the anterior compartment of our thigh. Then we have our obturator artery, which comes from the obturator canal. It's a branch of the internal iliac artery. Okay, and it's responsible for the supply to the medial compartment of our thigh. Then we have our inferior gluteal artery, which exits beneath the piriformis branch, again from the internal iliac artery, and is responsible for the blood supply to the posterior thigh and the gluteal region and the posterior compartment, as we just talked about. Nervous supply of the thigh muscles. We have the anterior compartment. Anterior compartment is supplied by the femoral nerve, L2 to L4. Medial compartment is supplied by the obturator nerve, L2 to L4. It has an exception, which is basically, if I remember correctly, the exception was the, one second. Yeah, the exception was the tibial part of the adductor magnus, okay? Which is supplied by the tibial division of the sciatic nerve. Okay, this is the exception to the medial compartment. Everything is innervated by the obturator except the tibial part of the adductor magnus. All right, continuing on, we have the nervous supply to the posterior compartment of the thigh, where again it's supplied by the sciatic nerve. We have two divisions of the sciatic nerve, as we mentioned earlier. We have the common fibular and the tibial division. Common fibular is responsible for the for the nervous supply to the short head of the biceps femoris only, and the rest are all supplied by the tibial division of the sciatic nerve. Okay, I'll quickly talk about the sciatic nerve again over here. Okay, the sciatic nerve supplies the hamstring muscles, as we know by now. Has two divisions: the tibial and common fibular. Tibial for everything other than the short head of the biceps femoris, and short head of the biceps femoris, which is supplied by the common fibular. As you can see, it's a very large nerve. It exits under the piriformis, and Yeah, that's all you guys need to know from the sciatic nerve. Remember, it's a very thick muscle, a very thick nerve. It's the thickest nerve in your body, in fact, and it's very obvious on the cadaver. So you guys should not have an issue identifying it. Just remember that it exits through the greater sciatic foramen again, which is underneath the piriformis, and the popliteal fossa will divide into the tibial and the common fibular nerve. Okay, and with that, we're done with the muscles of the thigh. Let's move on to the knee joint. Okay. Okay, so the knee joint. The knee joint, as we all know by now, is one of the largest and most complex joint in our body. It's primarily a hinge joint, but allowing for flexion and extension, but it also has some like slight rotation when it's flexed. Okay, it's primarily formed by a tibiofemoral joint and the patellofemoral joint. So again, name like the name says it's all the tibia and the femur. They both the medial condyles of the femur will go and articulate with the tibial condyles to allow for the tibiofemoral joint to form, and the patellofemoral joint will be formed when the patella interacts with the femur. Okay, so over here, you can see the quadriceps tendon, okay? Quadriceps tendon, again, from all your anterior thigh muscles. Then you have the fibular collateral ligament. You have your tibial collateral ligament, the fibula here, the tibia here. The tibial collateral ligament is also known as our medial collateral ligament, and the fibular collateral ligament is your lateral collateral ligament, which makes sense because the tibia is medial and the fibula is lateral, okay? Now, inside this joint itself, we have a few ligaments and menisci. So you have the anterior cruciate ligament, which goes from anterior to posterior. And then we also have the posterior cruciate ligaments, which you can't see right now, but I'll show it to you in a bit. Then you also have the lateral menisci and medial menisci, okay? Again, another picture of the knee joint. You can see the tibial collateral ligament, which is your medial collateral ligament, fibular collateral ligament, also known as your lateral collateral ligament. This is your tibia. Over here is your lateral menisci. One is your medial menisci. And yeah, this is the cruciate ligaments over here. You can see both of them. Let's start off with the ACL and PCL. We all have probably heard of ACL and PCL. So basically, what are these? So the ACL and PCL are basically cruciate ligaments that are found inside the capsule of the joint itself. So they're intracapsular ligaments. Cruciate means that they're cross-shaped, okay? So these ligaments are cross-shaped because they both cross each other, okay? They'll cross each other when they form. Anterior one way and posterior the other way. So the anterior cruciate ligament is basically responsible for prevention of the anterior displacement of the tibia on the femur, okay? So if this is the femur and this is the tibia, it prevents the tibia from moving forward, okay? That means that the ligament is going to go this way and attach to the tibia, preventing anterior displacement of the tibia on the femur. It prevents hyperextension of the knee, and it also presents with a positive drawer test, okay? I'll be talking about the drawer test later on, but it's basically a test that is done to confirm for a PCL tear. Next up, we have a PCL ligament. The PCL ligament prevents the posterior displacement of the tibia on the tibia on the femur, basically preventing the tibia from moving too far backwards. So that means the ligament is attached this way, so it goes from the anteriorly on the femur to posteriorly on the tibia. It presents with a positive drawer test, positive posterior drawer test when there is a tear of the posterior cruciate ligaments. Okay, let's look at them. So again, as we said, the ACL goes from anteriorly on the tibia to posteriorly on the femur, and the PCL goes from anteriorly on the femur to posteriorly on the tibia. Okay. We also have our medial and lateral menisci, which basically are C-shaped, less mobile fibrocartilage pads that allow for the joint to be deepened, and they also improve congruence, and they also are responsible for absorbing shock in your in the knee joint. Okay. The more commonly injured between the lateral and medial menisci, again, remember, is the medial meniscus, okay? And it is because you could think of it, it's more common for it to be injured is because it's much more less mobile compared to the lateral ligament, okay? So again, summary of the four ligaments that I just talked about. So ACL prevents the tibia sliding anteriorly. PCL prevents the tibia sliding posteriorly. Medial collateral ligament basically prevents valgus instability. So as you guys can see, valgus is when your knees basically they buckle towards each other. And the lateral collateral ligament provides varus stability, which is basically basically bow-shaped legs. It prevents your legs from bowing at the knee joint. Okay, let's talk about the injuries now. So when you have ACL injury, the tibia it basically has moved excessively forward compared to the femur. Okay, this will cause the ACL to tear. Okay, what happens? How do you test for this? Is that you do an anterior drawer test and you do a Lachman test. Okay, I don't know if I'm pronouncing that correctly, but Lachman, whatever. So how do you do these tests? Okay, so Lachman test is basically um, you hold the knee at a 20 to 30-degree flexed angle, and you basically pull the tibia forward, okay, to see if there is any laxity or any give, like it gives away forward. As for the anterior drawer test, the tibia is basically placed, the knee is flexed 90 degrees, and the tibia is pulled forward to see if it moves, to see if the bone moves forward, okay? Next up, we have the PCL tear. PCL tear occurs when the tibia move excessively posterior compared to the femur. It's basically very commonly seen in dashboard injury. Basically when the knee hits the dashboard and the tibia will move posteriorly, you'll have this sort of injury. Um, how do you test for this injury? Is that you do a posterior drawer test. Again, same thing as the anterior drawer test, but just in this case, you're pushing it inwards. So you put the knee at a 90 degrees flexed angle, so 90-degree right here, and you push the knee, push the tibia to see if there's any laxity or it goes backwards. Okay, now what's a common triad that you guys probably already have discussed and know by now is the unhappy triad. Is basically a classic injury that is seen in like football and stuff, where you have an ACL tear, MCL tear, and you have a medial meniscus injury. Okay, basically how this happens is that when you have a force that is applied to the lateral aspect of the knees from the outside, so it's a valgus force. Um, while the foot is planted on the ground. So you have the foot planted on the ground, and laterally you have a force, which is your valgus force, and this would cause this unhappy triad to happen. Okay, just keep this in mind. What are the ligaments involved in this triad, and you guys should be good. Now let's move on to the tibia and fibula. Okay, so we know our leg has two bones. Okay, the tibia and the fibula. The tibia is the more medial bone, and this is your weight-bearing bone. Okay, the fibula, on the other hand, is the more lateral bone, so it's on the outside of your body, and it's the non-weight-bearing bone. Okay, the tibia is the main weight-bearing bone. The main function of the tibia is to attach all the muscles, or serve as a muscle attachment site, and it's also there for stabilization via the lateral malleolus of your foot. Okay, I'll talk about that later. The landmarks that you want to know on the tibia are basically the tibial tuberosity. Okay, over here you have your medial malleolus. Okay, right here you have the medial malleolus, and that should be it. Like this is your shin bone. It's like the sharp part. If you run your hand over the medial aspect of your tibia, you'll see that it's like very sharp, and that's basically due to your shin bone. Okay. Next up, we have our fibula. So fibula, you guys don't need to know much. You have the head of the fibula that is articulating with the tibia. Then you also have the lateral malleolus, which comes from the fibula. Okay, and you have the fibular notch over right here between the tibia and fibula. That's all you guys need to know. Again, this is the dry lab pictures. So you have the tibial tuberosity, lateral and medial condyle, medial malleolus. So this is basically for your foot. I'll talk about that later. You have the intraosseous border. You have the medial malleolus. You have the fibular notch. Okay, between the tibia and fibula, you have the intraosseous membrane, and that's basically where the intraosseous membrane basically attaches to the intraosseous border. Lateral and medial malleolus again. Just remember that, and you guys are good. You guys should be good. Yeah. You don't need to know much about the tibia and fibula, honestly. Just not much to know, honestly. I don't think they'll ask about it much either. Very unlikely, but yeah. Moving on to our leg muscles. Okay, so our leg muscles can be our leg muscles have three compartments. Okay, you have your anterior, posterior, and you have your lateral compartment of leg muscles. All of these muscles are separated by fascia, and they're important in compartment syndrome. I'll talk about this later. So, let's start off with the posterior compartment of the leg. The posterior compartment of the leg has the most superficial. Has two groups. Okay, it has superficial group and deep group of muscles. Superficially, you have the gastrocnemius right here. You can't see it, but it's the gastrocnemius. You have the soleus and you have the plantaris. Okay, plantaris right here behind. So these are your superficial posterior leg muscles. Let's start and talk about each of them in depth. So we have our gastrocnemius muscle. Okay, the gastrocnemius muscle has two heads. Okay, the medial and lateral head. It's responsible for the plantar flexion. So makes your foot go like this, not like this. So if this is your foot, it allows for plantar flexion. So moves the foot downwards. Okay, so it's responsible for plantar flexion of the foot and flexion of the knee. Um, and this is basically part of the calf muscle. Soleus, on the other hand, is another plantar flexion and responsible for posture and standing, and it's also considered our anti-gravity muscle. Okay, it does not cross the knee, so it does not have any knee flexion activity. Plantaris, on the other hand, is a very small muscle over here, and it has very weak plantar flexion and very weak, and it has some small activity in what's it called? Small activity in your knee flexion. So it's both weak plantar flexion and weak knee flexion. That's all that you need to know about the plantaris. So again, let me read through this real quick. So gastrocnemius plantar flexes the foot at the ankle and also flexes the knee. Again, as we said, soleus is the most powerful plantar flexion of the foot. However, it does not have any knee flexion. Remember that because it has no connection to the knee. It's also responsible for your posture and standing. So it's an anti-gravity muscle. We have the plantaris next. It's weak plantar flexion and weak flexion of the foot. Weak flexion of the foot and weak flexion of the knee. Does not have any functionally important role. And then all of these muscles are innervated by the tibial nerve. Think about it. They're all connected to the tibia on the posterior part, so they're all going to be innervated by the tibial nerve, which comes from the sciatic nerve. Okay. Again, another picture. We can see our gastrocnemius right here, the two heads, the medial and lateral head of the gastrocnemius. Over here is the soleus right underneath it. Again, you guys saw this picture previously. So the gastrocnemius goes and attaches to the calcaneal tendon. Same thing with the soleus. You have the plantaris as well. Uh, More pictures over here. So we have the gastrocnemius, lateral medial, soleus right here. Um, Again, lateral head, medial head, and this is your soleus. Okay. Now, let's talk about the calcaneal tendon, okay? What the calcaneal tendon is your Achilles tendon, okay? You guys probably already know this, have heard of this. So, this is your Achilles tendon, is basically formed by the tendon of the gastrocnemius and the soleus. Both of these tendons will join together and form the Achilles tendon, which is the strongest and probably, I think, if I'm not mistaken, is the largest tendon in your body as well. Um, like thickest tendon. When it's basically it can rupture when there's a sudden plantar flexion. So if you suddenly plantar flex your foot, uh, for example, when you're jumping or something, it can cause it to rupture. And to test this, I don't know if you guys took it previously. Um, or to test it, you'll basically squeeze the calf tendon, and if the foot does not plant or flex slightly, that means the calcaneal tendon has ruptured. Ignore this, by the way. I wasn't sure if plantaris is part of the thing because in your slides it did say somewhere that plantaris is part of the calcaneal tendon, but that's not true. So just remember that the gastrocnemius and soleus are the two muscles that go and whose tendons will form the calcaneal tendon. Okay. Now let's talk about compartment syndrome. Okay. So um okay. Beneath your soleus muscle is that you have a soleus hiatus. Okay. In this soleus hiatus, you have basically the popliteal artery, vein, and the tibial nerve that will pass through this posterior compartment. So what will happen is that when there's compartment syndrome, pressure will start to build up inside the facial compartment of the posterior compartment, and this will cause the compression of the neurovascular structures. Okay. This will lead to ischemia and nerve damage. So I don't know if you guys took the six P's like pain, pressure, pallor, pulselessness, paresthesia, and paralysis, but these are the six P's, and they basically present in compartment syndrome. And how you will relieve this is basically you do a fasciotomy. It's a surgical emergency, so you have to do a fasciotomy, and this will relieve the pressure in the compartment. This can happen in your forearm as well. You guys probably already took this, but yeah. All right, so let's continue. Moving on to the deep posterior muscles. Okay, so deep posterior muscles, all of these muscles are innervated by the tibial nerve. The tibialis posterior is responsible for the wait. Posterior, wait. Okay, yeah. Okay, yeah. The tibialis posterior is basically responsible for the inversion of the foot and weak plantar flexion. It's just it basically is goes and supports the medial longitudinal arch of your foot. If there is dysfunction of this muscle, then you'll have flat foot. Then you have the plantaris, which is basically again there for weak plantar flexion and weak knee flexion. Or here you can see the tibialis posterior. Plantaris you can't really see over here. But yeah, if I'm not mistaken, plantaris should be a part of the okay. I have this here by mistake, guys. So the plantaris should not be here. But again, you have the tibialis posterior, flexor digitorum longus, flexus hallucis longus, and the popliteus, which are part of the posterior muscles. Okay, so again, the tibialis posterior is responsible for the inversion of the foot and weak plantar flexion, and it's also responsible for supporting the medial longitudinal arch of your foot. If there's dysfunction of the tibialis posterior, what you'll have is that you'll have flat foot. Okay. Next up, you have the flexor digitorum longus. Okay, flexor digitorum longus. This muscle right here. So the flexor digitorum longus is responsible for the flexion of the lateral four toes, okay? And the flexor hallucis longus is responsible for the flexion of the big toe alone, okay? The popliteus is basically there for the unlocking of the knee joint. So once you fully extend your knee will basically lock, okay? And to unlock and start to flex your knee again, you need the popliteus muscle to contract, and this will unlock your knee and allows for the flexion of your knee. Okay. Again, keep in mind that the deep posterior muscles are all supplied by the tibial nerve. Okay, so let's look at more pictures of the deep posterior muscles. So again, we have the flexor digitorum longus, which goes and supplies all the lateral four toes. The flexus hallucis longus goes and supplies the medial big toe, and then you have the popliteus muscle right here, responsible for unlocking the knee when you want to start to flex your knee. And again, another picture of the plantaris muscle here. Popliteus muscle is right here, so it wraps around, contracts and unlocks the knee to allow for flexion. Okay. Now let's talk about the anterior leg. Okay. So the anterior leg is supplied by the deep fibular nerve. Okay. So these are the muscles of the anterior leg. Okay. You have the tibialis anterior, extensor hallucis longus, and extensor digitorum longus. Okay. So tibialis anterior is on the lateral side of the tibia. Its attachment is to the first metatarsal, okay? And it's responsible for dorsiflexion, so it moves the foot upwards, the ankle, and inversion, so it moves the foot inwards, okay? Moves the foot inwards. It's the main muscle of dorsiflexion, and it also is responsible for preventing foot drop during walking. So if there is any deep fibular or peroneal nerve damage, it would lead to foot drop. This is something that you want to keep in mind. Again. Next up, we have our extensor hallucis longus. Okay, this extensor hallucis longus is origin again is from the fibula. Its attachment is the big toe, and is responsible for extending the big toe and dorsiflexing the ankle. Okay, moving the ankle upwards. Next, we have our extensor digitorum longus, whose origin is our tibia and fibula, and its attachment to the lateral four digits, and is responsible for extending the four digits upwards and for the dorsiflexion of the foot again. So anterior leg is for moving everything upwards, dorsiflecting the foot, moving the toes upwards, and yeah, that's all. Again, keep in mind the tibialis anterior is responsible for preventing foot drop when you walk. Okay. Now let's look at some more pictures. So over here, you can see the tibialis anterior. Okay. And then right next to it, you'll have the extensor hallucis longus for the big toe. So the tibialis anterior was right here, and it's the most medial. Extensor hallucis longus right next to it, and second most medial going to the big toe. And then you have the extensor digitorum longus, which goes through all the other four toes, responsible for extension of the toes and for dorsiflexion, moving the foot upwards. Okay. Another view right here. Extensor hallucis longus more medially, extensor digitorum longus more laterally. And yeah, you guys should have known this well by now. Okay. Now, let's talk about the lateral leg, okay? The lateral compartment of the leg is elevators, okay? It's innervated by the superficial fibular nerve, okay? It's lateral, so think about it. So lateral, we have the fibula, right? So laterally, these muscles will be more close to the fibula, and near the fibula, you have the superficial fibular nerve, which is a branch of our I forgot. But yeah, the branch that gives off the tibial and fibular nerve, you have the superficial fibular nerve, which is one of the branches, and it will go and innervate two muscles, okay? You have the fibularis longus and fibularis brevis, okay? So the fibularis longus is basically responsible for weak eversion of the foot, so moving the foot outwards. So if these were your 2 feet, this would be inversion and this would be eversion. The fibularis longus is responsible for eversion of the foot, and it's also responsible for weak plantar flexion, so weak flexion, weak movement of the foot downwards, okay? It inserts into the base of the first metatarsal and the medial cuneiform. Medial cuneiform. It passes under the foot and inserts into the first metatarsal. I'll show you a picture later on. Then we have our um, fibularis brevis, which is basically responsible for the eversion of the foot again and again. The same thing, weak plantar flexion. Both of them have the same action. However, the fibularis brevis inserts into the tuberosity of the fifth metatarsal. Okay, so make this distinction. One of them inserts into the first metatarsal, and the other one, the fibularis brevis, inserts into the fifth metatarsal's tuberosity. Okay. Now, let's move on. More pictures over here. So we have our fibularis brevis and longus. Fibularis brevis will go and insert into the tuberosity of the fifth metatarsal, while the longus will go across the foot and insert into the first will go and insert into the first metatarsal base and the medial cuneiform, and passes basically will go and pass under the foot. Okay, over here again we have the fibularis brevis, fibularis longus. You can see the fibularis brevis going and attaching directly over here to the fifth metatarsal. However, the brevis will go, longus will go, because it's long, so it has to take a longer route. You can remember it that way and go and insert into the base of the first metatarsal. Okay. Now, okay. Now let's move on to the bones of the foot. Okay. This is basically the last part of the anatomy portion of the OSPE crash course. So let's start here. So as we can see, we have the fibula laterally, we have the tibia medially, then you have the navicular bone, which is anterior to the talus on the medial side, and then you have the three cuneiform bones, which are basically the medial, intermediate, and lateral cuneiform, which are basically anterior to the navicular bone. Okay, anterior to the navicular bone. Then you have the lateral. On the lateral side, you have the calcaneus, which is your big heel bone, and it's the one that you feel when you, like, if you were to touch the heel and you press it in, you have this hard bony prominence. That's your calcaneal tuberosity. Then you have the cuboid bone, which is right in front of the calcaneus. Okay, on the lateral side. Okay. And then you have the metatarsals right here. Second, third, fourth, fifth. Fifth is the most lateral. First one would be your big toe, and then you have the phalanges. Okay. Again, another view. We have our talus. In front of it, you have the navicular bones. And in front of the navicular bone, and in front of the navicular bone, you have the medial, intermediate, and lateral cuneiform bones. And lateral to the lateral cuneiform, you have the cuboid bone. Okay. Then you have the metatarsals and the phalanges again. Okay. Again, everything that I just said in words. Talking again about the muscles. I mentioned them again over here, just for completion's sake and make it a little more clear. You can see over here is that you have your you have your tibialis anterior, okay, right here. You see this tendon. This is your tibialis anterior tendon. It'll go on the or it comes from the lateral side of the tibia and inserts on the first metatarsal, so on the big toe. Then you have the extensor hallucis longus, which inserts into the again the hallucis, which is the big toe, and then you have the extensor digitorum longus, which goes and inserts into the lateral four toes again. So the second to the fifth toe. And that's all regarding this. So again, everything that I had already mentioned, I'm mentioning it again right now. And then foot bones. No, this was meant to be a continuation of the foot bones, where I again mentioned the other muscles, the flexor muscles of the foot. So again, we have the fibularis brevis and the fibularis longus. Fibularis brevis again inserts into the fifth, the most lateral tuberosity of the metatarsal, and the fibularis longus inserts into the first metatarsal and the medial cuneiform, and it crosses underneath the foot diagonally to the diagonally from lateral to medial. Okay, so it's one of the lateral muscles, go from laterally to medially. Okay. You can see over here. You see this fibularis longus because it's a longer muscle, so it'll go from the lateral to medial, so it goes all the way across the sole of your foot and goes and attaches to the first metatarsal. That's it. Now we'll move on to the popliteal fossa. Okay, so What is the popliteal fossa? Popliteal fossa, basically, you have a cavity or diamond-shaped space behind your knee. Its borders are you have the superior medial, superior lateral, inferior medial, and inferior lateral border. Okay, superior medially has the membranosus muscle. Laterally, you have the biceps femoris muscle. Medially on the lower side, you have the gastrocnemius muscle, the medial head, and laterally, you have the lateral head of the same gastrocnemius muscle. Okay, so um, the popliteal fossa basically contains over here again you can see basically contains nerves and arteries. I'll be talking about these three in a bit in the next slide. So again over here I'll show you the wet lab image of the um, gastrocnemius. So you can see you have the semimembranosus and tendinosus, mainly the semimembranosus in my opinion that makes the popliteal fossa, and then you can see the popliteal artery right here, semitendinosus right above there. Semimembranosus. Then you have the rectus femoris right here, rectus femoris. But superior laterally, you have the biceps femoris muscle. Remember that, okay? Inferior medially, you have the inferiorly, you have the gastrocnemius, both the medial and lateral head. The medial is for the medial head side of the popliteal fossa, and the lateral is for the lateral side. That's all you need to know. So, from superficial to deep, you want to know the contents of the popliteal fossa. It's very common that they could ask it very easily, but it's very simple. Okay, everything starts with popliteal. So you have the popliteal nerve, artery, vein, and you have the popliteal lymph nodes and fat. That's all you guys need to know. It's very simple. Let's talk about the blood supply of the lower of the leg real quick. So femoral artery, again, as you mentioned for the third time by now, continuation of the external iliac. It'll give rise to the popliteal artery. Popliteal artery branches into the anterior tibial and posterior tibial. Anterior tibial is responsible for supplying the anterior compartment of your leg, and it also continues as the dorsal pedis artery supplying the toe. And you also have the posterior tibial artery that's responsible for the posterior compartment, and you have another branch which is the fibular artery responsible for supplying the lateral component of your foot. Okay. Now let's talk about the nerve supply of the lower leg. Okay, we start off with the sciatic nerve. Sciatic nerve will branch to the common fibular. This is what I forgot. The sciatic nerve gives off the common fibular and the tibial nerve. So sciatic nerve will give the common fibular and the tibial nerve. Common fibular will further divide into the superficial and deep fibular nerves. Superficial fibular nerves. You don't need to know the sensory innervation. Just know the responsible superficial fibular nerve is responsible for the anterior compartment of the leg, and the superficial fibular nerve is responsible for the lateral compartment of the leg, and deep fibular nerve is responsible for the anterior compartment of the leg. And posteriorly, you have the tibial nerve. The tibial nerve is responsible for supplying the posterior compartment of the leg. Okay, with that, we're done with the anatomy portion of the OSPE crash course. Okay. Okay, now we'll start to discuss our the EMG lab that you guys had. So what even is EMG? Okay, so EMG stands for electromyography, and it is the recording of the electrical activity that is generated by your muscle tissue. Okay, when a muscle fiber will contract, it will fire an action potential, and this signal is basically detected by your electrodes that are placed over the skin of that muscle. Okay. So what we're basically doing is that we're capturing the propagation of these action potentials along the muscle fiber, and the result is a waveform that will reflect the real-time muscle activity. I'll show you guys in a second. Okay, so let's talk about the structure behind the EMG function in the first place. Okay, so each muscle fiber, there are much more muscle fibers in your body compared to your motor neurons, right? So to handle this, each of your axons, once they go, or either each of your motor axons, once they go inside a muscle, they will branch. Okay, once they branch, this allows them to this allows for a single axon to supply multiple individual muscle fibers. Okay, these muscle fibers, they're scattered across the muscle rather than they're grouped together in a circle in a singular place, and this is basically the distribution of. Okay, again, these muscle fibers, they're scattered widely across the muscle rather than clustered together. And basically what this means is that the contractile force will be spread across the muscle evenly, and it will not be concentrated on a singular part of the tissue, okay? Not all of the motor neurons will be created equal either, okay? So the small motor neurons will innervate very few muscle fibers, while the larger ones, of course, will innervate much more larger ones. However, at the same time, the small ones are more responsible for the fine-tuned movements. For example, I don't know, writing with a pen or something that needs delicate, precise movements. And that's what the small alpha motor neurons will innervate, okay? Next up, we have our load and motor load load and motor unit recruitment. Okay, the motor unit, which is MU as shown over here, according to your doctor slide, is basically your alpha motor neuron plus all the muscle fibers that it innervates. Okay, it's basically the functional unit of a muscle contraction. So, how is the force regulated? So once the demand on a muscle increases, so like you want to lift a heavier object or like you're straining to lift something up, what the nervous system will do is that it will recruit more muscle fibers. So more muscle units, okay? So once it recruits more muscle units, there'll be more muscle fibers that will contract simultaneously, and so a greater, bigger, larger force will be produced overall, okay? So this is where your EMG will become useful, okay? So when the magnitude of the EMG will become much larger when you have multiple motor units being recruited. As you guys can see over here, when there's one motor unit being recruited, there's force, of course, but this force is not enough to lift the load that we want to. So then you'll recruit the second motor unit, okay? And now what will happen is that this first and second motor units will combine together and lead to a much larger, greater force being produced, okay? How do you perform an EMG in the first place? What you do is basically you have disposable ECGs and you place them on the skin over the biceps or as shown over here, or the biceps and triceps to detect any electrical activity that is generated during muscle contraction. Okay, the electrodes will then be connected by a lead wire to bioamp, I think it's called, yeah, to a bioamp, which will then transmit the signal to the recording to the recording system. Okay, at the same time, you have a wristband which goes and connects to the ground, to the earth. Okay, what this basically does is a ground electrode, and it reduces any interference and improves the signal quality overall. And then you also have the bioamp. Let's talk about the bioamp. So what the bioamp is basically therefore is, like in its name itself, bioamp is basically amplifies the process of the EMG and amplifies these signals and before they're displayed on the recording device. Okay, what this will basically allow is that it allows for the comparison between the biceps and the triceps during different movements. Okay, now once we actually record, what do we see on our recorder? So this is what we see. Okay, over here you can see the green trace. This green trace represents your biceps, and this blue trace represents your triceps. Okay, so over here you can see that there's a lot of electrical activity in the biceps trace, but not in the trace. I'll talk about this later, but it's basically because muscles are antagonistic pairs. The biceps and triceps are antagonistic pairs. When the biceps is contracting, the triceps is completely relaxed, so it's not going to contract. So there'll be no wave patterns produced by the triceps electrodes. Okay. So let's talk about interference patterns. So when there's maximum voluntary contraction, when a person has basically contracted their muscle as hard as they can, so many muscle units will be firing simultaneously that their individual action potentials will basically start to merge together, and you cannot differentiate them. Okay, so you cannot differentiate individual motor units, and they all are basically very closely grouped together. So what this will create is an interference pattern. Okay, so over here we have three interference patterns shown. Okay, this first one is a normal interference pattern, full dense, you have high amplitude, and this is completely normal. Okay, over here you have spinal muscular atrophy. Okay, this is a neurogenic condition where fewer motor units are available for contraction, and so the pattern will be reduced and sparse. However, you actually have the normal amplitude. You have the amplitude is fine and normal, but the gaps but the pattern will become it will have gaps and will be very sparse. Next up, we have polymyositis. Okay, this is a myopathic condition. So, spinal muscular atrophy was a neurogenic condition, and polymyositis is a myopathic condition. So, neurogenic is a disease with the neurons or the conduction, and myopathic is a disease in the muscle itself. Okay, remember this. So, in the polymyositis, which is the myopathic condition, the motor units will be present, and they will all be innervated by the nerves normally. Okay, so once the nerve fires, the muscles get innervated, the muscles will be stimulated, and the motor units will try to contract. But the issue here is that the force created by the muscle is very small because the muscle fibers themselves are damaged. Okay, this will lead to very small, short amplitude fibers. However, the density is fine. So that means the nerve conduction is fine. However, the muscles themselves are damaged. Okay, this basically is one of the main uses of EMGs. They allow us to differentiate between myopathic and neuropathic diseases very easily. Lastly, we have our antagonistic pairing of muscles, as I mentioned earlier. Almost all of your muscles in your body, they have opposing pairs. Everyone knows about your biceps and triceps. Once the biceps is contracting, the triceps will relax, and once the triceps contracts, the biceps relaxes. Okay. Again, you saw that on the EMG when there is antagonistic pairing. When there's a antagonistic pairing, one of them will be completely flat, while the other one will have the normal waveforms. So yeah, that's all you need to know with regards to this. I doubt, honestly, you guys will have a question from the physio lab. In the past, from what I saw, I don't think there was any physio questions, but honestly, they could very well bring up a waveform like this waveform and ask which one is normal, or ask like identify each of them and label them. So it'll be very simple, honestly. Inshallah, don't worry about this. If they do bring a question. So now that we have done all the material, let's move on to the questions for my part of the crash course. Um, okay, so starting off with this, okay? I want you guys to pause the video as I read the question and try to answer it yourself, okay? Starting off with, name two features of this process. This is some process that I mentioned earlier on. What is the process shown and what is the pink layer shown? Pause the video now. I'll move on to the answers. So, okay. So what is this process that is shown? Basically over here, the mesenchymal cells are differentiating into your osteoprogenitor cells, and this allows them to proliferate and form the layers of osteoblasts and the network of developing capillaries forming your bone, okay? This process, as you guys can see over here, does not have any cartilage, okay? So that means what type of ossification is this? This is our intramembranous ossification, okay? Pink layer on the outside, you can see over here, is our osteoid, and this osteoid is deposited by our osteoblasts, which are these cells on the outside over here. Next, at which layer of the epidermis does this process of cornification, which is keratinocyte differentiation, begin? Okay, I'll give you a few seconds. Make sure to pause the video. Now, okay, this process is seen in our third layer over here. What is the third layer? This is our stratum granulosum. Okay, so the layer where the keratinocytes start to flatten and they start to accumulate keratinohyaline granules. This is where you have the step of cornification taking place, okay? So cornification, as we said earlier, was the process by which the keratinocytes would lose their nucleus and organelles, and they will start to fill with keratin. And the process will begin in the stratum granulosum, and it will be complete by the time you get to the stratum corneum, okay? Again, the answer over here. Next up, what is the structure shown and what is the function? Pause the video. Okay, so if you guys remember, I told you guys to keep in mind whenever you see an onion-shaped structure, just instantly you go to Pacinian corpuscle, okay? So this is a Pacinian corpuscle, onion-like structure. The function of the Pacinian corpuscle, as you guys know, is that it's found on the plantar surface of your foot, as mentioned in your histology slides, and it's responsible for deep pressure and touch detection, okay? It's a mechanoreceptor, converts these mechanical pressures into electrical signals, and you can detect it by your body, okay? Moving on, what is this test shown, and if this test is positive, what ligaments could be damaged? Again, look at this carefully. You see the tibia being moved anteriorly, so that means that this is damage to the anterior cruciate ligament, okay? So this test is testing the anterior cruciate ligament. So this test's name is anterior drawer test. Okay, you're pulling it anteriorly, so the anterior drawer test. You rest the you flex the knee at a 90-degree angle, and you pull the tibia anteriorly to see and test for the anterior cruciate ligament. Okay. Next up, what is this structure? Okay, so we can see that this is lateral and this is medial. So that means we're looking at the right knee. So you can see this ligament that goes from the posterior aspect of the tibia to the anterior aspect of the femur. Okay, so that means that this is the posterior cruciate ligament. Okay, so it goes from posterior to anterior. So if this is the lateral view, it would attach from over here on the femur and go over here on the tibia. Okay. Next up, which segments are tested by tapping the structure labeled over here? So they tap the structure over here, and what would be the nerves that are stimulated? Okay, so as we said earlier, we have, okay, this first of all, identify what this is. This is the foot, okay, right? So on the foot we have the large ligament, which is our calcaneal ligament, okay, also known as your Achilles tendon, okay. So Achilles tendon is formed by our gastrocnemius and is formed by our soleus muscles, okay, as shown over here. These are the muscles, and these will converge to form the calcaneal tendon. The muscle, the nerves that are stimulated once the tendon is tapped is the S1 and S2 spinal segments, causing the jerk of the soleus and the actually soleus and the gastrocnemius muscle. Okay, and that is the last question that I have. Make sure you guys go over the slides as well. Um, these slides as well, as a lot of the information that I said and talked about are all mentioned in the slides themselves. Make sure to memorize the nerves and make sure to know the blood supply very well. And with that, I'd like to end this crash course. I don't have any more questions. Make sure to do the past questions. Um, I'd like to end this crash course. Thank you all so much for watching. If you guys have any questions, feel free to text me or Salma anytime. I'm sure we'll be happy to respond. Do scan the QR code and let us know what you thought of the OSPE crash course. And if you guys have any comments, anything that you guys think we should improve, do let us know. We're always open to feedback. And again, inshallah, you guys got this. This is the last block exam of the year. You guys are almost second years. And you guys got this well, inshallah. The exam is going to be very light. MSK is one of the nicer blocks in first year. Among the nicer blocks, like literally very beautiful block, very nice block. Very simple, alhamdulillah. Just you know it, you memorize it, and imagine it on yourself, and you're so good to go. And yeah, thank you all so much. And Assalamu alaikum.